orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900.
Show 1 2 days 1 2 3.
16
1 2.
Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 070659900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the Hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG, and cephalometric X-rays, including lateral, frontal, and bite wing views. Dentition scans for orthodontic evaluations. Hotline 0706599900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations, hotline 0706599900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations, hotline 0706599900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral, frontal, and bite wing views, dentition scans for orthodontic evaluations, hotline 0706599900. Visit us at number 16 Mulgampola Road, Kandy. Apex Health is now in the hill capital of Kandy, bringing advanced dental imaging for precise diagnostics and treatment planning. We offer 3D CBCT imaging, delivering high-resolution scans for implants, orthodontics, and surgical assessments. Our specialized dental imaging services include CBCT 3D scans, OPG and cephalometric X-rays, including lateral.
Good morning, ladies and gentlemen. On behalf of the Kandy Dental Society, it is my pleasure to welcome you to this prestigious workshop and trade exhibition, Revolutionizing Dental Diagnosis, Advanced Application of DPT CBCT in Implant Planning, Surgical Removal of Impacted Teeth, and Emerging Global Trends in Maxillofacial Radiology.
We are honored to have with us today esteemed professionals who have dedicated their expertise to the advancement of dentistry.
Ladies and gentlemen, please rise for the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo, 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 Namo Mata. Sundara Siri Barini, Surani Ati Sobhamana Lanka. Ranya Dhanaya Nekamal Palaturu Piri Jaya Bhumiya Ranya.
Thank you, ladies and gentlemen. Please be seated. To honor the rich tradition and culture of Sri Lanka and to illuminate this special occasion, we would like to invite the following dignitaries to join us with the lighting of the oil lamp. Our guest of honor, Dr. Sandhya Abeyratna, Consultant OMF Surgeon, National Hospital, Kandy.
Our guest of honor, Dr. Senaka Talagala, Regional Director of Health, Kandy.
Our esteemed speaker, Dr. Ajay Parihar, Professor and Head of the Department of Oral Medicine and Radiology, Government College of Dentistry, Indore, Madhya Pradesh.
Our esteemed speaker, Dr. Hemant Mathur, Professor and Head of the Department of Oral Medicine and Radiology, Pacific Dental College and Hospital, Udaipur, Rajasthan.
Dr. Nisanka Senaratna, President of the Kandy Dental Society.
Dr. Udara Malmessa, Secretary of the Kandy Dental Society.
Dr. Imran Muhsin, Managing Director, Apex Health.
And one course participant representative.
Ladies and gentlemen, please rise. Thank you. Please be seated.
It is our distinct honor to extend a warm welcome to several esteemed guests who have graced us with their presence today. Dr. Nandana Kularatna, Consultant in Restorative Dentistry.
Dr. Iranjani Leperuma, Consultant OMF Surgeon.
Dr. A.M.H.K. Abesingha, Consultant OMF Surgeon.
Dr. Y.S. Muhammad, Consultant OMF Surgeon.
Dr. C. Devi Veerasurya, Consultant Orthodontist.
Dr. Latmal Kulasekara, Consultant in Restorative Dentistry.
Dr. Lakmina Ekanayaka, Government Dental Surgeons Association.
Dr. Prabodha Navaratna, Gampa Society of Dental Surgeons.
Dr. Rohana Karyavasam from Medidens.
Dr. Azela Vijayaswandara from Rosewood.
And Dr. Madhubani Disanayaka from Dantaja.
It is now my pleasure to invite Dr. Nisanka Senaratna, President of the Kandy Dental Society, to formally welcome you all to this gathering.
Good morning, ladies and gentlemen. It is with great pleasure and pride that I welcome you all to this groundbreaking workshop, Revolutionizing Dental Diagnosis, Advanced Application of DPT, CBCT in implant planning, Surgical Removal of Impacted Teeth, and Emerging Global Trends in Maxillofacial Radiology. At the outset, I would like to extend a warm welcome to our guest of honor, Dr. Sandhya Abeyratna, Consultant in Oral and Maxillofacial Surgeon, National Hospital, Kandy. Your presence here is truly an honor, and we deeply appreciate your continued support for the advancement of dental education and practice. A special welcome to our esteemed speakers, Professor Ajay Parihar and Professor Hemant Mathur, who are experts in this field. We are grateful to have you with us today to share your valuable knowledge and expertise. I also warmly welcome our invited guests, course participants, and our generous sponsors, without whom this event would not have been possible. Today marks a historic milestone for the Kandy Dental Society as we bring to you the first ever workshop of its kind in this region. The importance of digital imaging and modern dentistry cannot be overstated, and this workshop is designed to provide deep insight into the latest advances in CBCT, DPT, and maxillofacial radiology. The Executive Committee of the Kandy Dental Society has meticulously planned this event, ensuring that it will be a truly enriching experience for all of you. Our goal is to bridge the gap between traditional dental practices and cutting-edge imaging technologies, helping us enhance diagnostic accuracy and treatment planning for our patients. I am confident that today will be a fruitful day filled with learning, innovation, and networking. This workshop is not just about acquiring knowledge, but about shaping the future of dentistry in Sri Lanka. So let us engage, explore, and make the most of this wonderful opportunity. Thank you once again for being here. I wish you all the insightful and productive day ahead. Thank you.
Thank you, sir, for your warm and inspiring words. We now take a moment to express our gratitude to our esteemed speakers. Firstly, I would like to invite Dr. Udara Malmessa, Secretary of the Kandy Dental Society, to present the token of appreciation to Dr. Ajay Parihar.
Thank you, sir. Next, I would like to invite Dr. Nimanta Abesurya, Executive Committee member of the Kandy Dental Society, to present the token of appreciation to Dr. Hemant Mathur.
Thank you, sir. They say a picture is worth 1,000 words, so let us capture this special moment with a photograph. I kindly request the Executive Committee of the Kandy Dental Society, our esteemed speakers, and the guests of honor to gather on stage for the official photograph.
With that, we officially commence our scientific sessions for today. So let's delve into today's insightful presentations led by our expert speakers, Dr. Ajay Parihar and Dr. Hemant Mathur. The stage is over to you, sir.
Okay. Slide. Yes, yes. A very good morning to one and all, respected guest of honor for today's morning. For today's, the day is 26 January, and it is very auspicious for India as well as for Sri Lanka, because today is Mahashivratri. So one of the auspicious day and the most festive day we celebrate in India, and we used to take fast, and it's a lovely day. We the lot of temples which are surrounded by devotees of Lord Shiva. So, and today I came to know in the morning from Dr. Samira that today is a holiday, public holiday in Sri Lanka too. So I am Dr. Ajay Parihar, and I am from Indore. Indore is considered to be the cleanest city of India from last 10 years. And I'm working as a professor in a government dental institute from last 16 years. I've been into teaching from last 20 years. And I started CBCT centers in way back 2011. It was first in India. So, and I see few faces which I have met probably in some conferences or international conferences. And last time I came here, it was Asia Pacific Conference in Colombo in 2009. So that was the first time I came there. And this is my second time in Sri Lanka. And particularly at the outset, I want to thank Dr. Samira and his team, Candy Dental Society, for inviting me and giving me this opportunity to share my experiences with the patients, with the CBCT, with the implantology, and my field particularly is oral medicine and radiology. It is not confined to only radiology. It is also involving the oral medicine part. So and you can see it in my cases that you will have a good idea about the pathological aspects of the disease too. So moving forward, this is for Dr. Samira. This slide is for Dr. Samira, that great things do not just happen by impulse, but as a succession of small things linked together. We were friends, and Mr. Shiva Kumar is standing behind from KS team. He is working from last 30 years in KS team, he told me. And I'm having multiple CBCT centers in India. So most of the machines are from KS team, few machines are from Action, that is called as Triumph. So this is my department where I'm working in Government Dental College, Indore. This is my staff, the backbone. And these are few people through whom I have learned, not about the subject, but about the life, about learning how to learn. The first is Dr. A.B. Surveyor. Yeah, at that photo, I'm looking very, very young. So it was my PG, postgraduate time photo. So Dr. A.B. Surveyor was a direct student of Dr. Burkitt. If you have heard about Burkitt's oral medicine textbook. So he was a direct student of Burkitt, and he was considered to be the pioneer in starting oral medicine as well as radiology in India. The second is Dr. Umarji. He is also from Government Dental College, Mumbai. He is very senior and very authentic leader and a teacher. The third is from Chennai, late Dr. N. Gyanasundaram, who has contributed a lot for the academy. The fourth, the last one picture is of Dr. Arai from Japan, who founded and who invented this technology that is called as cone beam CT. And this is my fellowship picture, and this is again Dr. A.B. Surveyor. So Dr. Surveyor has written one very small textbook, and if you find it at online, you must read. That is 100 pages book, very small book, that is called as the Art and Science of Oral Radiology, where he has put 100 cases, just 100 cases, one case in one page. It's a beautiful book to understand and to know about the field of radiology. This is my alumni, Kaylee Belgaum, from where I did my master's. And this is the family, my wife. And the other picture is my brother, Dr. Himant Mathur, who is the other speaker, and his family, Nehal, which we call Tiger. So the common thing is that in my family, everybody starts with A. My name is Ajay, my wife is Aarti, starts with A. My son Arjun starts with A. Daughter Arya starts with A. And he is very lucky that he has his wife, her name is Aditi. She also starts with A. So this is our journey from 2011 when we started first CBCT center. And at that time, nobody was there in, not even in Asia, but not even in world to teach, because it has recently evolved. In 2009 and 8, it has come up, this CBCT technology. So nobody was there to train. So how to train ourselves for reporting and to diagnosing CBCT, because we have read all the pathologies, what you have read in oral radiology, or you have seen probably because of the OPG or because of the other extraoral radiographs. But how the pathology appears in CBCT and how to report that, it becomes very difficult. So we have to learn ourselves. So this is our journey from 2011 to 2015. So we have 9 different centers in different cities, different parts of Madhya Pradesh, central part of India. So before jumping into cone beam CT, there are 2-3 things which are very important to understand. I have never reported a single case of CBCT before until unless I have a good clinical history of the patient. The clinical history, the final diagnosis always remain with you, with the practitioners who practice. These are just additional tools to help you to decide to coming to the final diagnosis. But it is the clinician, because he interact with the patient. Always remember, the diagnosis comes out from patient mouth. Allow him to speak. Very important to understand that more you interact with the patient, the better chances and a better prognosis for your diagnosis. So this is few lines, the maxims of medicine by Suzy Kassin. There is a very nice book written by Suzy Kassin on diagnosis. Rise and salute the sun, the writing of Suzy Kassin. Before you examine the body of a patient, be patient to learn his story. For once you learn his story, you will also come to know his body. Second, before you diagnose any sickness, make sure there is no sickness in the mind or heart. For the emotions in a man's moon or sun can point to the sickness, any one of his other parts. Third, before treat a man with a condition, know that not all cures can heal all people. For the chemistry that works on one patient may not work for the next. because even medicine has its own condition. And the most important, the last lines, that before asserting a prognosis on any patient, always be objective and never be subjective. Never be subjective. For telling a man that he will win the treasure of life, but then later discovering that he will lose, will harm him more than by telling him that he may lose, but then he wins. So before coming to CBCT, I want to emphasize 2-3 important aspects. That interaction with your patient and taking a good clinical history will give you a better diagnosis. That is the main important aspect. So what is CBCT? It is called as cone beam CT. So in medical CT, we use spiral kind of radiation, but here we are using cone shape. So we are taking multiple lateral cephalogram kind of images and we are joining them together. And then we are sectioning it. It is just opposite from medical CT. And it is different from CT and MRI. The reason be because of the voxel size, because of the price, I'll later tell you. And it has tremendously less radiation doses in comparison to CT scan. And the most important thing is when somebody is doing MBBS or from medical side, you know, in India, the radiology particularly is not a exam. It's not a paper for undergraduates. It's a super specialty kind of thing. So in undergraduates, MBBS first year to final year, nobody learns about radiology. And even in radiology, when somebody is doing MD radiology, he has been only aware of 2 pathologies. One is called as dentigerous cyst and second is amyloblastoma. That's all. The chapter is closed. But being as a maxillofacial radiologist, being as a dentist, we know that there are thousands of pathologies and there are n number of diseases which can affect oral mucosa and oral structures. So it is, so this software, CBCT, why it is better than CT? Because it has a dental friendly software. You can trace the nerve, you can plan an implant, you can plan your orthographic surgery, you can do a number of things with the help of software. It is less time consuming, definitely you don't have to change, it takes hardly 8 seconds. And better image quality because of the voxel size. So you have heard about pixel, one word, pixel, camera pixel, 4 pixel, 8 pixel. So pixel is picture element and voxel is volume element. So that is a difference between 2D and 3D. So pixel is for 2D and voxel is for 3D. So better image quality and dialect with the referring doctor. Like once you send some case to a maxillofacial radiologist and he can interact and he can tell you better about the disease. Advances in CBCT technology is tremendous. Tremendous means every year you are going to have some new thing in CBCT, some new thing in the machine, every year. So when I started way back in 2011, like 15 years back, at that time I got a machine which I have limited scope, that is called 9, but at that time it was the greatest machine. But now the machines are coming with MAR, metal artifact reduction. You can trace the endo canal also. You can measure exact length of where is the accessory canal, where is the lateral canal. So many things I'll show you in the cases. And it is economical. It is much cheaper than CT scan or MRI. Then why CBCT when you have a CT scan? What is the requirement of another technology that is called a CBCT? So the first is because of the implantology. Necessity is the mother of invention. So necessity was implantology, and because of the implantology, the CBCT has grown up like bounds. In 2009, there were only 3 CBCT centers in India. Right now, there are more than 3,000 CBCT centers in India. So that is the huge transformation occurred because of the implantology. Then for endo and conservative dentistry, earlier we use CBCT means implantology. Whenever you want to plan an implant, otherwise you don't need CBCT. But no, now 60% of patients who are referred to us is for endo and for root canal anatomy. Then periodontal procedures and diagnosing periodontal disease, orthodontic surgeries, impactions, cleft lip and palate, sleep apnea, airway analysis. Then non-odontogenic odontogenic pathologies and malignancies. Then temperamental joint disorders. And there's so many systemic diseases which are manifesting in jaw, bones particularly. So in those aspects, it's very important tool, a CBCT, which gives you some direction that there might be some systemic disease which is affecting the patient. Then paranasal sinus diseases and salivary gland disorders. But when you have to use the root canal cases which are not responding, still they are complaining of pain, then you should have a CBCT scan done. Probably there is some mesenteric canal, probably there might be a lateral canal, probably there is some calcification. So first is for root canal cases which are not responding, chronic orofacial pains, pathologies, implants, any disease which require a third dimension, very important to understand. And any disease related to TMJ, sinuses and other maxillofacial regions, trauma, fractures, and for pediatric pathologies. So this is, I have written in one of my editorial. I was editor in Indian Journal of Oral Medicine and Radiology. So at that time I have written, the advent and easy access of the technology has also affected the importance of clinical diagnosis through interaction and observation. Students, practitioners and faculty rely more on investigations and less on the history of illness, clinical examination and psychosomatic aspects of the patient. This not only leads to longer time in diagnosis but also obstructs oral radiologists in giving clear and better radiographic impression. So it is very important. Again, I'm emphasizing that CBCT will not help you until unless you have a good clinical history. And if you are not telling your differing radiologist that what exactly this patient is suffering from, we cannot report a DICOM file. We have to report a patient problem. So for that, we need a good clinical history, very good clinical history. So to educate, so William Osler has said, to educate, the eye to see, the ear to hear, and the fingers to feel takes time. That is why diagnosis is a bit more art instead of science. It is an art. I cannot teach you in one day about the whole aspects of this art which is called as diagnosis. It has to be learned every day with every patient. Every patient is a new patient. Every patient teaches you something new. So you have to, it is an art. It comes. So what is diagnosis and how much any advanced imaging contribute in the final diagnosis? So there are two things which are very important. Art of observation. So when I'm teaching my students, my postgraduate students, I always tell them that you don't have to focus on oral cavity. There are some other body parts which are open to see, observe what is happening with. So lichen planus cases, particularly oral lichen planus cases, where this oral involvement, they have a skin involvement also. So normally most of the times the feet are involved. So you can see the lichen planus lesions on the feet also. So it is very important to observe, to interact with the patient. And second is the art of communication. We have never been taught in our graduate time as well as in postgraduate time of art of interacting the patient. It is very important to understand that it is the patient who is going to give you the diagnosis through his mouth. So developing that confidence in the patient to tell you the truth is very important. So interaction is very important. And Plato has described communication practices way back. It is a different topic, so I am not go into it. So we basically rely on this picture, that is OPG, most of the times, right? Most of the times we rely on this picture. And there are 4 checkpoints, always remember. A wrong radiograph will give you a wrong diagnosis. A right radiograph will give you a right diagnosis. So how to assess whether the radiograph is right or wrong? So there are 4 checkpoints. One is your condyle should be on the same height. They should be on the same plane. It means the patient has not turned his head on either way, on left or right. Second, there should be a smiling curve. If a smile curve is there, the neck position is right. Then you can see, able to see the central incisors, upper and lower. It means the neck, the spine is not superimposed over it. And third, the ramus height should be same of the right and left side. So these 4 checkpoints are very important to say, yes, your radiograph and your patient positioning was done correctly. So these are few advantages of OPG. That is why before coming to CBCT, the three important aspects. The advantages is it is most useful for pre-operative assessment, and it is easy procedure, good vertical dimension, very good vertical dimensions comes in OPG, but poor horizontal dimensions. So that is why we cannot rely. And one thing you should always remember, any pathology or any kind of bone evaluation of height or for implantology or for impacted tooth, don't rely on OPG for posterior maxillary pathologies. Anything which is there in the posterior part of maxilla, you should not rely on OPG. I will show you the cases why you should not rely on OPG. The disadvantages are non-uniform and horizontal distortions, positioning artifacts, decreased resolution versus IPA. IPA is having better resolution even than CBCT. No cross-sectional information we are getting from OPG, superimposition and ghost images. So OPG gives you multiple kind of features. Like in this radiograph, can you make out that what exactly is happening with the outer cortical border here on this side? You see the cortical outline. It is faded. It is a case of hyperparathyroidism where there is a generalized bone loss. You see the trabecular pattern. So OPG gives you multiple informations, not only about teeth, about the systemic diseases also you can make out. In osteoporosis, hyperparathyroidism, you will see the loss of this outer cortical outline. But if you see the previous OPG, here the cortical outline is intact. So it is very important to assess the OPG for the cortical outline. So in hyperparathyroidism it is. So what is exactly CBCT is a specific technology which has created a revolution in maxillofacial imaging, facilitating the transition of dental imaging from 2D to 3D images and expanding the role of imaging from diagnosis to image guidance of operative and surgical procedures via third-party application software. So we have n number of machines. We have different CBCT machines. Like in Candy, we are using Myray. We have KS Team, PlanMaker, then Gendex, Action, Triumph, Prime 3D. So there are multiple n number of machines. But 15 years back, there were 2-3 companies were there. Hardly 3 or 4 companies were there in the market. But now we have more than 30 to 40 different machines. So these machines, they have a DICOM files. So where the image data, the patient data is saved in the form of DICOM. So DICOM files can be opened in any software. Any machine software can be downloaded, and you can use any DICOM files and you can open that data. So I told you that it is the necessity was the implantology. Because of the implant, the CBCT has come. Now this makes a difference. Okay, you see this image and you can observe a fracture line on the right side. There is a fracture in the body of mandible, oblique fracture. But it makes a difference when you have the third dimension. Third dimension is very important. Now this will make you clear that why we need a third dimension. Because in OPG we are seeing a single simple fracture line present on the right side of mandible. But when you see this image, you actually know what is happening with the mandible, where is the fractured part, what it has affected the tooth or not. If you see on the right side that the roots are away from the bone, the fracture has displaced. So this kind of information you will get it in CBCT. And if you see in the OPG again, you are not able to find that this kind of destruction of the same patient, but you have a different image here. So medical CT versus CBCT, there are 4 major differences you have to understand. One is the radiation dose. 90 to 95% radiation doses are less. If you go for a bilateral TMJ scan for a CT scan, and if you compare the doses of cone beam CT, they are almost 90% less. First thing. Second, a CT is reported by a medical radiologist. However, a CBCT is reported by a maxillofacial radiologist. That makes a huge difference. That makes a very huge difference, because we only study about the jaws, about maxillofacial pathologies. So we are far, far better in reporting when we are reporting for maxillofacial etiology. The third difference is it is less time consuming. In CT you have to change the dress, then you have to go to gantry. Some patient might be claustrophobic, they don't want to go into that gantry, but here's in CBCT, patient have to stand, and within 8 seconds, within 1 circle, the scan is done. So these are the other differences in CT. That is why don't we have Hounsfield unit or something, some standard unit or grace in CBCT? The reason being, because in medical CT, we take slices first with a spiral mode. We take slices and then we join the slices with the help of software and make it a volume. This is volume. These are slices. So in medical CT, we are joining with the help of software, we are joining these slices, right? But in cone beam CT, because of the cone shaped fan beam, we are taking full volume first and then we are cutting into slices. So that is the difference, that you cannot repeat the same gray scale values even after second exposure, because the volume is different. So this is one of the major differences. This is CBCT, and this kind of image you can reconstruct. Then you have to understand about the field of views. Field of views, what area of interest? Like for trauma or for pathologies, you need a larger field of view. But as you increase the field of view, your voxel size will be increased. As your voxel size is increased, the image quality will be reduced. So if you want a better image quality, if you are going for an endo, then always ask for single tooth. So if single tooth scan, it is 70 micron. 70 micron means 0.07 mm. So the details will be much finer when you have a decreased voxel size. So we have multiple field of views. So this is pixel versus voxel. So as you increase the voxel size, the image quality will be of less, with less details. And if the voxel size is low or minimum, then your image quality will be better. So this is how we scan the patient. We generate this kind of lateral ceph kind of images, and with the software, we reconstruct the volume, and later on we can change the slices. So radiation doses are less. From full mouth IOPA, the radiation doses are almost 50% from full mouth IOPA. And for OPG, it is almost 26 microsievert. But for a CBCT, normal CBCT, you will get 68 microsievert, almost double radiation doses in comparison to OPG. But medical CT can expose as much as 1200 to 3300 macrosievert. 3000 macrosievert for bilateral TMJs. Okay, and compare it with the CBCT, it is 68 macrosievert. So radiation dose are almost 95% less in comparison to medical CT. So once you have that CBCT data, you are able to see these 4 images. One is called axial, when we go from superior to inferior, from upper to lower part. So when we are cutting those sections, suppose it's a kind of, what juice we had in the morning? Watermelon, yeah. So watermelon slices, so these are axial sections. And sagittal, when we go from right to left or left to right, these are sagittal sections. Then coronal, when I go from anterior to posterior, these are coronal sections. And oblique coronal or customized coronal, when we want to plan an implant, when we want to put an implant, we need our sections in oblique coronal. And after CBCT data, you can reconstruct it like this. These are called as 3D volume. You can reconstruct OPG, lateral ceph, PA, AP, any view you have if you have a CBCT data. So these are 2 important, very important cross sections for implantology. This is for maxilla, this is for mandible, where we will have the bone height as well as the bone width. So both the things are there. So it is very important in implantology, these sections particularly, oblique coronal sections. But to use CBCT, what do you need? You need a computer. and or a laptop. So this is the ideal specifications. Your laptop should be having a graphic card to actually run the CBCT volumes. So it is very important. These are basic details. One, graphic card is very important. Others are very basic, 4 GB RAM, 369 GB hard disk, 512 MB graphic cards, Windows 7 or more. Now Windows 14 has come. So it is very basic details which we require for a laptop. And this is the case team software which we are using, which we have given to you, and in the workshop we'll give you a few cases to trace the nerve and for implant planning. So this is orthogonal slicing. The first slice, if you see, it is orthogonal slicing. So for all the large lesions, cystic lesions or large pathologies or fractures, we rely on orthogonal slicing. Then curved slicing we reconstruct this kind of image, and then we have a cross section here which appears in this, that is cross section. So for implant planning, we rely on curved slicing. Then custom slicing, when we want to compare right with the left side, right TMJ or right maxillary sinus with the left TMJ or left maxillary sinus. And the oblique slicing when is used for endo purposes. Oblique slicing. Oblique slicing we use for endo purposes because the canal is not straight, it is oblique. It might be curved. So we need this section, particularly oblique slicing, for endo purpose. So they are basic anatomical landmarks, major anatomical landmarks, that is mandibular canal, mental foramen on this side. Then this is how TMJ appears in first is axial image, second is sagittal image, and third is coronal image. So how TMJ appears in 3 different sections. And we have forget about this thing, the major, very important aspect. So before CBCT, we thought that all those temporomandibular joint disorders, they arise from this condylar head. We have never thought that there might be something in the glenoid fossa or this temporal part of bone, which is very equally important in occurrence and etiology of temporomandibular joint disorders. I'll show you very interesting few cases. So this is how this maxillary sinus appears. This is posterior superior alveolar artery on the upper side, then sinus floor. This is alveolar crest. This is alveolar bone. This is the inferior alveolar canal. So it is not nerve, it is canal. We are simply observing the canal, not the nerve. And this is the IOPA. If you see the root, the dilaceration of root on 3D, so it gives you a different picture. This is fracture. I'll just skip few slides. Genial tubercle. So these are the major anatomical landmarks which you have to understand before entering into implantology or putting an implant. You have to understand that these anatomical landmarks you must be aware of. So I'll just take 2-minute pause, and I need a leading question from the audience that what exactly you want to know about CBCT. Leading 3 questions. Anyone? One is implantology, everybody is having in mind, right? Any other thing other than implant? Okay. So we'll start with the impactions. So for not all impacted teeth, you need a CBCT scan. In OPG, if you are finding it that it is away from inferior canal, then you don't require a CBCT scan. You simply, it can, with the help of IOPA or OPG, you can take a help of IOPA, and that is fine. But there are cases in which you require, like this one. If you see this case, this one, central incisor, which is impacted, right? So when you take a IOPA, it appears that the root is resorbed, right? Even you can feel it after seeing this picture, that if IOPA, if you have taken IOPA, it appears that root is resorbed, but root is not resorbed. When you go for a third dimension, it is 90-degree dilacerated. So your treatment plan completely changes. when you have this kind of image, that it is dilacerated. It is not it is impacted, dilacerated. Now, what kind of extraction you will plan for this? And if you have seen only this IUPA where the root is up, so your treatment plan completely changes. Like in this case, you see the dilaceration of the root here. So that these kind of pictures you will get only through CBCT, cone beam CT. You will not get it in IPA or OBG. You need a third dimension for not all cases, but yes, for the cases which are closer to nerve, inferior nerve, for the cases which are impacted and which are giving a different morphological alterations, you need a CBCT scan or third dimension. Like in this case, this is simply impacted, horizontally impacted canine, but you will get multiple information. If you see, there is a labial cortical bone perforation over there, this side. So you know exactly where you have to put your knife, where you have to go for surgery. Like in here, there is a perforation of labial cortical bone. Again, impacted tooth, impacted canines. So there is an impacted canine here on the labial side, but once you subject your patient for CBCT scan, you get multiple information. Like, can somebody tell what multiple information I'm getting other than this impacted canine? We are getting an information that all these central incisors and lateral incisors, they're two rooted. They're double, two canals are there. So this is an additional information I'm getting. Then dilacerated root and the association with the inferior nerve. This is a mesodens, impacted mesodens, which is causing pathology. Now that is why I told you that the pathologies which are present in the posterior part of maxilla, you should not rely on OPGs. Like in this case, can you diagnose like how many teeth are impacted? It's very difficult to actually number the teeth. But if you have a 3D image of the same patient, you will get a better picture that there are multiple supernumerary teeth which are impacted in different part of the maxilla. Like here also, the patient was complaining of pain in right side of eye, and we took our OPG, it was not there, but there is displacement of 1/8 in the infraorbital region, which is causing pain to this particular patient. I'll show you 2-3 cases. Okay, so this is how we interpret the CBCT images. The first one is axial images. So here we can see multiple impacted teeth. So these are two central incisors, 1 and 2. There are two lateral incisors and two supernumerary teeth. So if you see this particular picture, you will have a better idea that what exactly is happening inside this patient. So there are different tools. The first tool here, which I'm clicking right now, this one, this is for gray imaging, like black and white or contrast or brightness if you want to increase. This is for the second picture. This one is for 3D. So if I want to make some changes over here, particularly here, so I can make all these changes. If I enlarge this image, you see, there are two central incisors. The canines are impacted or developing. And where is the lateral incisor? Can somebody tell me whether this is lateral incisor or this one is lateral incisor? First one or second one? Second one. Yes, this is the lateral incisor and this is supernumerary teeth. So both supernumerary teeth are impacted. Any other interesting finding over here? He has a supernumerary lateral incisor also. He is having two deciduous lateral incisors. two deciduous lateral incisors along with two impacted supernumerary teeth with impacted lateral incisors. So I told you that for impacted teeth, you have to rely on oblique imaging. Like here, the impacted teeth is, this canine is impacted. Here the canine is impacted. So if I want to know much about the canine, though, I'll fix all my axes perpendicular to the impacted canine. And now I know how it has impacted, where exactly is the root. It is going below the maxillary sinus, just lateral to the nasal bone, and it is not causing any root absorption and all. Now this is the third case. This is important to understand because most of the times we subject our patient for CBCT because of this thing, impacted molars. So this is impacted molar. So in curved slicing, if I go to curved slicing, so what I'll do, I'll just delete what I have formed. I'll show you how to trace the nerve. So first I'll generate a OPG kind of image by clicking. So in CBCT, any software, single click means you are doing the job and double click means you are finishing your job. So here I can see a OPG kind of image or IUPA kind of image. Now I'll make it thin section, that is 75 macron. So if I make it thick, it will appear like a IUPA or OPG. But if I make it thin, it will appear like this. So I'm just scrolling it to find mental foramen. So mental foramen is not here, but I'll just try to see where exactly is nerve. Okay. So you see this particular radiolucency or hypodense area. This is the nerve part. I'll just trace it, single click, then scroll. I'll again scroll, and I'll keep on clicking where I'm finding this inferior nerve. Now, in this picture, I know that where exactly, what association of inferior nerve with this tooth, this particular teeth. And if you want to see more, then you go back here. Now, you focus on this section. You focus on this one. If I go posteriorly, so I can see the nerve as well as the impacted tooth. And if I go more posteriorly, now you see it is coming very near to teeth, middle part of the teeth, and it is located on the lingual side, and the root is placed on the buccal side. So we know exactly what is the location of inferior nerve and what is the association of inferior nerve with the impacted molar. So there are a number of anatomical variations also. Anatomical variations, the reason being, earlier we were, if we want to subject some patient for temporal joint disorders, we ask them to go for a MRI or CT scan. But CT scan, the voxel side is large. So the finer details, we will not get it in CT scan. We will get it in CBCT. So now the things which were considered to be common, they have become rare. And things which were considered to be rare, they have become common. Because we are able to see inside what is happening. Like in this is very important to understand. Bony inostosis or idiopathic osteosclerosis. So it is a dense bony island in the bone, and that is the reason why this interdental space is not getting close even after orthodontic treatment. The reason was the bony inostosis was present at the apex, so the tooth movement was restricted. This is again a mylohyoid process, very rare. It is one of the single case which I have found in my practice. I have not seen in textbooks also, like this is mylohyoid process. So the patient was complaining of pain in deglutition on the tongue area. So that was the reason. So here the patient was complaining that whenever he touches after extraction of last molar, it was extracted because of pericoronitis, and after tooth extraction he was complaining that at one particular point in my oral cavity, if I put my finger and pain starts. Suddenly pain starts. So the reason was not, the culprit was not this particular thing, radiopacity over here, which is a fractured instrument. Reason was accessory inferior alveolar canal, very common. It's not rare, it's very common. So please, once you extract last, and particularly in last molar area, the accessory inferior alveolar canal is very common. Torize, mandibular torize, and maxillary torize. These are anatomical variation I'm showing you. This is important to understand. If you see the first picture, you can see the displacement of these central incisors on the left side. And if you compare, so there are two very important aspects to understand. One is, always see what is happening on the opposite side. If there is some lesion in the buccal mucosa on the right side, try to see what is happening on the left side. Same with the radiology. What is happening on the opposite side? So here, if you compare the size of, so the patient was complaining she was not able to put forces, occlusal forces, while chewing. And what is the reason? Reason was this. Hyperplasia, idiopathic hyperplasia of the temporomandibular joint or condylar head, which is causing occlusal problem in that young girl. Okay, this is question for audience. I want to awake you. It's almost 1 hour now. So it is a question for audience. Which chocolate is famous in candy? Candy name itself, it means a chocolate or toffee. Okay, so I'll gift a chocolate, whosoever answers. What is the anatomical variation? I told you two things. Compare right with the left, upper with the lower. So if you see here, we have a mental foramen. But you see there is no mental foramen on the opposite side. Absence of missing mental foramen. That is anatomical variation. So this patient come for implant planning on 6, but there was no mental foramen here on the opposite side. So now this is important to understand one thing. So whenever any pathology, if you see, there is a periapical pathology here with the 5 or first premolar. And when I go anteriorly, I am able to see the mental foramen. This is mental foramen, and the part is called as mental canal now. It was a part of inferior alveolar canal. There's a mental canal also. So there are two foramens. It appears to be a two foramen, but it is not. One is the periapical pathology, which is perforating the buccal cortical bone, and second is the mental foramen. So for trauma cases, like for hairline fractures or crazed lines in orthodontics, you can take help of CBCT. When the patient is complaining of pain, if you see atresion, if you see that he is using more occlusal forces, then there must be chances of hairline fractures or root fractures. These kind of fractures you will not able to see in IUPA. Classical Lefort-1 fracture and fracture of the condyle where it is dislocated. Can somebody tell why it is always going towards the medial side? Which muscle is pulling? There is one muscle which is pulling the condyle on the medial side. And why it is fractured? Can somebody tell me why it is always fractured from subcondylar region, not from the head? You have seen, somebody has got trauma here, he will get a subcondylar fracture. Not the condylar fracture, subcondylar fracture. It is the evaluation. So, Homo sapiens, they were, you know, I told you about the glenoid, I showed you glenoid fossa. It is very thin. It is 2 millimeter bone, which is present above the condylar head. If you perforate that glenoid fossa, the condyle will enter into middle brain and the person will die. So through evaluation, what has happened? The nature has turned the condyle and made the subcondylar region into 37 degree and made the subcondylar region so frickle that if somebody gets trauma, immediately it will fracture from subchondral region. Why? To protect the middle brain. So it is the through evolution. That is why subchondral fractures are very common in comparison to condyle fractures. And these fracture, hairline fractures of the condyle, this you will see only in CBCT. Oh, flying molar. I have seen in the morning a lot of monkeys outside my room. They are waiting. We were having breakfast and they were waiting that they should have something, and lot of crows were there. And it's very green city. So a lot of flying birds I have seen. So this molar is also flying in pterygomandibular space. It is iatrogenic. So how to diagnose these fracture, teeth or hairline fractures? So one thing you have to understand, when you are observing a CBCT data, try to see what is happening with the periodontal ligament space. It's a craze line or it is a fracture, it's a hairline fracture. If it is a fracture, there will be widening of the periodontal ligament space. So you see this case, this is a gift box for a dentist because you have 4 different teeth to treat. So one is fracture. I'm focusing on this premolar. One is fracture. So I'm going axially, I'm scrolling it down from upper to lower part. So one information you are getting over here after seeing this picture, there is a fracture, definitely. Second information, what you are getting, you are having a lateral canal, accessory canal. It is not opening at the apex. The apex is calcified. You see the apex is calcified. But while going up, you will have this canal, root canal, and the tooth is fractured from the root. Now, additional information. If you see the adjacent teeth, this second premolar, if you see the first premolar is fractured, if you see the second premolar, you have 2 roots and you have an accessory opening, accessory canal. You see the lateral canal here? Are you able to see? The second premolar. Now the third coming posteriorly to 6. So it is endodontically treated, but there is missed, devoid of restoration, these mesial canals. If I go more posteriorly, I can see a carious lesion here. So we call it as hypodense area, which is involving enamel, dentine, and pulp also. It is involving pulp also. So additional information. And the fourth information, so it's a ATM kind of thing. So you will have to treat this tooth also. The last molar is also carious and it is involved. So for root canal, suppose if I want to see these particular 2 roots, I'll go in oblique slicing and I will focus on only these 2 roots particularly. I make it parallel, this axis make it parallel with the mesial roots. Here also. Now in this image, you can see both the canals. And you can measure the canals also. You can measure from here the canal length. The exact canal length you can measure. So all these things you need not to have this any other tool once you have a CBCT data of that particular. So it is 12.7. So from where and whatsoever you want to measure, you can measure it. So all 2 canals, all canal anatomy I can see here. So the third, this important aspect, why I am going to speak on maxillary sinus diseases, because in post-COVID, have you, any of your, the practitioners have seen mucormycosis cases after COVID-2? Just, I want to, any mucormycosis cases? You have seen, yeah. So, sir, you'll not believe that we have seen almost more than 300 cases of mucormycosis in my city. And we have a scan, and I'm very confidently saying it that it is a wonderful tool in diagnosing initial mucormycosis cases. In comparison to it is far better than CT and MRI. I'll show you the cases how. So this is important, the fracture of the floor of maxillary sinus, and there's a displacement of the root in the maxillary sinus, perforation of the maxillary sinus after extraction, displacement of root within the sinus after extraction. Then this is the case. This is the very initial lesions. So if you see these hypodense areas on the left side, these are the very initial signs of mucormycosis. Very initial signs of mucormycosis. Rather than calling at mucormycosis, I've done my PhD on the same topic. I used to call it as avascular necrosis. Because a lot of cases where QH is negative, a lot of cases where mandible is involved. So these are the very initial signs which you cannot see in CT or MRI, and why this particular area is involved. If you have noticed it, the premolar region, most of the time I have seen so many patients where the root canal has been attempted, where the extraction has been done, where periodontal surgery has been done, because the initial complaint of the patient is mobility in tooth or pain, mild pain in the tooth. So in the premolar region, why premolar region? Because maxilla is inverted pyramid shape, inverted triangular shape. So the peak or the cone or the tip always remain where? On the second premolar region. So second premolar and first premolar are the first tooth which are involved in initial mucormycosis cases. Like in this case, if you see, and as mucormycosis, we call it as avascular necrosis. So all these are the very initial signs of avascular necrosis. Post-COVID, after the second wave, we have seen a lot of patients. If you see this case, so the maxilla is involved, and the primary reason is this one, premolars. Premolars, because the inverted pyramid shape of maxillary sinus. So normally ENT surgeons, they do rhinoplasty and they perforate the middle concha and they perform the surgery for mucormycosis. But the tip of maxillary sinus always remain over there. So infection remains still after ENT involvement. So this is the initial site of destruction. This one's the initial site for destruction. So these are the very advanced cases where the full maxilla is gone, or if you see the mandible, it is pure, it's within 15 days. When I saw this patient, there was only involvement of the right side, just a small part of posterior mandible. And within 15 days, the full, from right condyle to left condyle, the full mandible was involved. And it was massively destructed. So it is better to call as avascular necrosis, probably because of the vaccine, probably because of the COVID virus. So these are the initial features, or these are the advanced cases. Now here, if you see this video, so this patient was complaining of pain, and there was a history of trauma. So on this side, if you see, there is, that is pearl drop appearance of injury in infraorbital lesion, which is causing pain and numbness to the patient. I'll show you one case. So for maxillary sinus cases or for any other sinus, we rely on this image, that is coronal image. So we try to see all the maxillary sinus or all the paranasal sinuses with the help of coronal image. We'll enlarge it and we'll make it thin, because you have to always see the CBCT data in the thinnest slice to actually observe the details. Maximum details you will get in thin sections. The moment you make it thick, it will become like a PA view or a OPG view. So you make it thin and then you scroll down and you see what is happening over here. So it is the soft tissue pathology of the maxillary sinus. Why it is soft tissue? And you see these black dots within the sinus. This is the pathology which is involved. So these are aerosols. These are aerosols, okay, in chronic maxillary sinusitis. It is not at this level. If it is at this level, it is fluid, it is water, or it is sinusitis, but it is raised. It means it is a soft tissue pathology. It is dome shapes, it is mucocele or sinus mucocele. So calcifications, it's 10:13. Okay, so if you see, these are salivary gland stones in parotid gland. On the first and second image, on the lower side, it is salivary gland stone in the, and very small. And you know, why it is important to take a CBCT in this stone? You know, it is exactly at the opening of Stenson's duct. So what you have to do, you don't have to perform a surgery. You just give pilocarpine 10 milligram for 5-6 days and it will come out naturally. That is stone. Even same for this submandibular gland also. We have seen with the help of pilocarpine, we have taken out large salivary stone also. These are phleboliths. These are another calcifications, phleboliths in hemangioma, central hemangiomas. And it also causes pressure because it is a chronic disease. So it also causes pressure and displacement of the condylar head. Then rhinoliths, and this is calcification facial artery because of the age. Then calcified lymph node. Can somebody tell me where, in which disease we see calcified lymph node? It is very common. In India particularly, it is common. In most of the country, it is obsolete. In tuberculosis. So in tuberculosis patient, we see calcified lymph nodes. Okay, this is a question for audience. The patient is complaining of pus discharge from lower lip from last 6 months. And we took a CBCT scan. Although it was a soft tissue, ideally I should have not taken a CBCT scan for this patient because it is a lip, it is a soft tissue. Why to go for a CBCT scan? What exactly it is? If you remember my 2 words which I have told you very initially, try to see what is happening in the adjacent areas. When you observe some pathology, always try to see what is happening on the upper side in the maxilla. What is happening with the lower side? Compare right with the left. Compare upper side with the lower side. And if you see closely, there was a history of unconsciousness. And patient said, I fall down. And somebody took me to hospital. And the suture has been done on head. Nobody has seen, just wiped the lower lip. And that fractured tooth got embedded in the lower lip from last 6 months. And it was causing problem. So your diagnosis starts from here. What exactly is the reason? And you know, can you believe that this patient has been diagnosed with this fractured tip, with this embedded root piece in the lower lip, ultimately came into diagnosis into neurocysticercosis. We diagnose it as neurocysticercosis. The reason of is chronic history of unconsciousness. We get an MRI done and this case came out to be a neurocysticercosis. So the simple things in the oral cavity, and you name a disease, you name any disease of the body, I'll tell you that what exactly is the oral manifestation. Every disease, whether it is of mind or whether it is of body, whether it is psychosomatic disorder, it reflects in oral cavity. It appears in oral cavity. Most of the seismic disorders. Anyway, so this is another case. This is another case of calcifications. You see multiple calcified lesions over here. So it is odontoma. This is a case of odontoma. Now in CBCT, you can actually see what is the size of the lesion, how to operate, where should we go for our surgical approach. Now this case is again odontome, complex odontome, which is present in the posterior part of oral cavity. One additional information you are getting here. Other than this odontome, what additional information you are getting here? This one. That inferior alveolar nerve is entrapped in the impacted molar. So taking out odontoma is easy, but how you will proceed for this particular case where the nerve is entrapped between both roots. So you have additional data. When you have a CBCT scan, you have multiple informations with you. So that was complex odontome because it was same radiopacity. It was appears as a same radiopaque lesion. But here in this odontome, you have denticles. You have enamel-like structures. So when you have an enamel-like structures, it means it is dentical. It is compound odontome. This is peripheral osteoma. That's a beautiful picture if you see the first one. So how beautifully it is coming out from the bone, originating from the bone. The cemento-ossifying fibroma. So that is a classical appearance of cemento-ossifying fibroma. So there is a non-ossifying fibroma also, which is present in the long bones, but it is cemento-ossifying fibroma. This is ossifying fibroma on the lower part of mandible. So for periapical pathologies, not for all the endo cases we subject our patient for CBCT scan, but yes, for few patients you need to subject your patient for third dimension when you have these kind of cases, like there's a pulp stone, large pulp stone, or in central incisors there are 2 roots or 2 canals. So in these patients you need a help of, or missed canals. These are common things, very common things that happen with the patient. Or resorptions, internal resorptions or external resorptions of the root. Like here, the central incisor is resorbed and the other lateral incisor is also resorbed on the apex part. Okay, the first one is internal resorption, this one. Can somebody tell what exactly is happening here on this side? So that is called as palato-gingival groove. Very important finding, that is palato-gingival groove. The palatal aspect of the tooth is so grooved that it is making contact with the canal, root canal, and the patient is complaining of pain. Extraction is the only solution for these patients. So there is periapical pathology which has perforated the maxillary sinus. So odontogenic reason for maxillary sinusitis is very common. So when you have a CBCT scan, if some patient is complaining of pain, and you see this kind of perforation, after treatment, absolutely it is fine. The floor is closed and the bone is healed. So this is the second picture. If you see, there's a radicular cyst. There's a radicular cyst. But can you see something over here? That is dens invaginatus. So dens invaginatus leading to periapical pathology, leading to radicular cyst. That is one thing. But again emphasizing the same thing, try to see what is happening on the other side. If you see the counter lateral incisor, it's also having a dens invaginatus. It is also having a widened canal. And if you see closely, the periapical pathology has started. The periapical pathology, if you see, there is a radiolucency in the periapical region. So this cyst you have diagnosed, and you are prophesizing to the patient that after 6 or 7 months or after a year, you will have a same kind of pathology what you are having on the right side. So that is the reason I have named my CBCT centers in India in the name of Oracle. It is called as Oracle CBCT. So if you have heard about one movie, that is Matrix. Have you seen Matrix? Anybody? Nobody has seen Matrix movie. Okay, it's a very nice movie. You must see that movie. Very old. So there is a lady which is called as Oracle who prophesies about the future. So this is prophesizing that you will have a periapical pathology or radicular cyst very sooner or later because of this dens invaginatus. So very interesting case. And that is it tells you about the importance of interacting with the patient. The patient was complaining of pain. It was a pericoronitis. The teeth was extracted. After 6 months, even this patient is complaining of pain. So always remember, whenever there is a mesioangular impaction, try to see whether it has eroded the distal aspect of 7 or not. Because most of the times the mesoangulary impacted teeth, it is placed below the cervical region and it erode this particular part, the distal aspect. So this was the reason for pain. And who has suffered? This poor last molar has been extracted. The reason for pain was 7. The patient is still complaining of pain. So I'll show you 2-3 cases of endo. I hope I'm able to connect with you all. Yeah. After? Okay. Right. Thank you so much, Thilma. Even I need a break. So it is 10:30. So we can proceed with the endo implant and rest of the part later. We can have some discussion on T. 10:45 we will start with. So I have 15 minutes more. Okay. So all those endo cases which you are planning for endo, you have to only rely on only one section, that is called as axial sections. Axial section will give you all the information of canal anatomy. If you see the first case, this is the region we took a CBCT scan. What about this root? See closely. This is crown. Okay. This is crown. When I go downwards, I can see 3 canals. One is widened canal, distal canal, and 2 mesobuccal and mesolingual canals. Now it is divided. This widened canal is again divided into 2 canals. So we have 4 canals, right? But see here, it is radix. This one is radix. Right. So parapal pathology related with radix because it is more lingually oriented. But you have additional information about this tooth also. There is a periodontal bone loss on the distal side, which is also leading to parapacal pathology. For maxilla, same, rely on axial sections. Axial sections. Endo means axial. Endo, remember always axial. Endo, axial. So whenever you want to see any canal pathology, if you want to see the canal anatomy, if you want to measure the canal length, you have to rely on axial sections. So here in maxilla, if you see this 1-7, right? So it has 3 roots, 3 canals, 3 roots and 3 canals. And this, 6. And 1-7, you see this. So most of the times in maxilla, particularly 1-7, it is C-shaped. Most of the times. Very common. So it is C-shaped with 3 canals, 1, 2, and 3. One is calcified. This one is calcified. You see, it is calcified. Calcified and very much narrowed. Now, if you see this case, again, this is axial section. I'll start from top to bottom. Axially, this is the filling restoration. There is a secondary caries also I can see over here, and there is a restoration on the mesial aspect of 7. So 6 I am evaluating. So if I go downwards, there are 4 canals which are endodontically restored, right? But if you see, there is some line here that is called as streak effect or metal artifact. Okay, so I have a feature. If you see this button on the screen, this one, if I switch on this, and then now you see, If I remove this part and if I go inside it, can you make some difference? That streak effect is gone. So for endo cases, for fractures where metal restoration is there, so a lot of times you will have a streak effect which appears to be like a fracture, which appears to be a fracture. Like in this case, it appears, if I remove this, you see, it appears that there is a fracture over here. But when I apply this metal artifact reduction or MAR, M-A-R, MAR, when I apply this into endo cases, then this metal artifact or streak effect is lost. So that is the beauty of this one. So you can use in post-endo cases. In post-endo cases, you have to apply metal artifact reduction. In next case, again for endodontic purpose, now you see there is a parapacal pathology. It is endodontically treated. All the canals are wonderfully restored here. But still there is a parapacal pathology, and the reason for parapacal pathology, if you closely observe this 3-6, sorry, if you closely observe 3-6, I'm going downwards. So these two canals, they merge together into single canal. And you see parapacal pathology here, hypodense area here, radiolucency over this side, only one root. So there must be some problem in this root, distal root. What is the problem? Go downwards, and I can see it is a accessory canal. You can see accessory canal over here, this one. So that is not restored. That is leading to parapacal pathology. So endo treatment has been done up to this place, then there is an accessory canal and apex is still on the lower aspect. Another case. So these lines what you see, and these are called as streak effect, beam hardening effect. We also called as beam hardening effect in CBCT. That is the drawback of CBCT. Here we can see a calcified canal, completely calcified canal, the lower aspect. 3 canals, but the buccal canals, both the buccal canals and this mesobuccal as well as distobuccal, both the canals are calcified in the lower aspect. And that is the reason for parapacal pathology. This is the last case. After that, we will take a tea break. I'll also have a water break because I'm speaking for the last 1.5 hours almost. But this is quite common. Okay. Some practitioners, they want to save money, so they have missed one canal. To restore or to save the endodontic material, it is very costly. So they have missed one canal, and it is for the future. After 6 or 7 month patient will again come. This is, so all these missed canals, accessory canals or lateral canals, or the treatment has been done and still patient is not responding. Probably CBCT will help you a lot. So with this note, we will take a tea break, and probably this was intentionally, it was coincidence that this slide has come for a break. Want the good news or the bad news first? Good news, please, doctor. Well, they are naming a disease after you. You got that joke? And the second one, doctor, I have a bad news and a worse news. The bad news, you have 20 hours to live. Guy, and the worst news, doctor, I meant to tell you yesterday. So have a nice break. We'll have a coffee or tea, and then we'll join together after half an hour. Thank you.
Ladies and gentlemen, we will now take a short break. Please enjoy some refreshments served at the Flamingo Hall on your left-hand side. We will reconvene in 15 minutes for the continuation of the scientific sessions. Also, we kindly request you to visit the stalls at the trade exhibition. Thank you. Ladies and gentlemen, we expect to start shortly, so we kindly request you to take your seats. We kindly request you to take your seats.
Can we proceed further? So sincere people who are very sincere, they have come and I respect that. So I'll start my lecture. Right? So this part particularly we will discuss on temporomandibular joint disorders and how to diagnose cyst. You know, all those appearances what we have read in our textbook, honeycomb, soap bubble appearance, ameloblastoma. So all these appearances occur in a radiograph because of the superimposition of the structures. That is why they appear like a honeycomb or a soap bubble, cotton wool appearance, or different appearances of pathologies. But when we have a CBCT, because in CBCT you are seeing slices of 0.075 millimeter. That thin slices you are observing in CBCT. So there is no superimposition. So your terminologies will also change. Ameloblastoma, calling it as a soap bubble appearance in CBCT, it is not possible. You can see a soap bubble appearance in OPG or in some other radiograph, but not in CBCT because you are seeing simple sections. But if you make it more thick, so these sections means 0.75 micromillimeter, that thin section. And if you make it 20 mm, it will appear like a OPG image. Got my point? So for endo cases, always remember, for endo cases, for implant, for single implants, you have to go for a smaller field of view, because a smaller field of view will give you better details. And larger field of view, because we have to full scan full maxilla and mandible. So we need a larger field of view. So voxel size will increase. Okay. Starting with one simple case over here, and you see there are two things you should always remember in differentiating between OKC and ameloblastoma. More destruction and more expansion, ameloblastoma. More destruction and less expansion, it is odontogenic keratocyst. It is basic, simple difference. More destruction, extensive destruction, but you have minimal, very minimal expansion. That is odontogenic keratocyst. And odontogenic keratocysts are more common than ameloblastoma. Ameloblastoma are rare in comparison to odontogenic keratocyst. So this is how I'm increasing the thickness. So increasing the thickness, it will give you this appearance, and increasing more, it will give you a different kind of appearance. Now you can say it is a soap bubble appearance, because I have increased the thickness. I have made it like a OPG. Now you see a soap bubble appearance over here. So that is why, because I have increased the thickness. If I have not increased the thickness, then it will not appear like this. Simple classical appearance of a radicular cyst. So you can measure the boundaries, the destruction, the resorption, the expansion, what particular bone is more involved, whether it is lingually more involved, whether it is buccally more involved. You can measure the distance. This is a case of residual cyst. Now you see the OPG, and can you suspect any pathology in this OPG? Can you suspect any kind of pathology in this OPG? So probably you will focus on this impacted teeth, this one, 2-8. So that is why I'm again re-emphasizing that pathologies which are present in the posterior part of maxilla, you should not rely on OPGs. The posterior part of maxilla, the pathology is here, but you are not able to see. I can see as a radiologist, there is a destruction of innominate line. This is a posterior border of maxilla, and this is an innominate line. If you consider on the opposite side, there is a missing innominate line. So there is a destruction over here. But you are not able to see, is there any dentigerous cyst? No. Is there any pathology? No. There is a simple impacted 2-8. But if you see the CBCT data, there is a huge radicular cyst associated with 2-8. But here I am not able to see. The extension of the pathology, it is huge. If you see, it is involving the concas also. This is inferior concha, this is middle concha, this is upper part of concha. So it is involving up to this region. So such a huge pathology, which is seen here in CBCT scan, or if you see this picture, particularly this one, so there is a huge pathology which is not seen here in OPG. So that is the reason why I am telling you that the pathologies, or even for implantology also, you should not rely on when we are having some posterior part of maxilla. Posterior part of maxilla, you should not rely on OPG. The reason is this. There is a huge pathology, but you don't see it in OPG. So I told you that there is a huge destruction with expansion, but I can see the knife edge root resorption. So knife edge root resorption means it is an aggressive pathology, which is ameloblastoma. So I told you, again, always remember, more destruction and more expansion. I can see huge expansion with impacted tooth. So more expansion, more destruction, it is ameloblastoma. and less expansion and more destruction, it is OKC. So this case is ameloblastoma. That is a classical case of ameloblastoma. But if you see the first picture, see the expansion over here with the impacted tooth. So this is ameloblastoma. This is desmoplastic ameloblastoma. It has a calcifications. So that is a classical case of this is OKC. You see the migration of the teeth and the expansion of labial side as well as on the buccal side, and see the destruction. So huge destruction from right side to, and whenever the pathology crosses midline, it means it is odontogenic keratocyst. Always remember. And there is a huge destruction but minimal expansion. That is why it is OKC. And if you compare with the previous ameloblastoma, there is a huge destruction, but there is huge expansion too. But here expansion is minimal. Or in this case, you don't see an expansion. There's a simple mandible. If you see the mandible, you see some destruction on the buccal side, but you're not seeing expansion over here, but you see the destruction. It's a Gorlin-Ghost syndrome. Multiple OKCs. From right side to left side, there are multiple cystic lesions on the mandible. So more destruction, but minimal expansion, means odontogenic keratocyst. Here also, earlier it was, so in my lifetime when I started post-graduation, it was called as odontogenic keratocyst. And when I was giving my exams in 2002, it was called as KCOT. Then again in 2016 when I was into teaching, then again it was renamed as odontogenic keratocyst. In my lifetime it has been changed four times, the terminologies. And that is the classical picture of fibrous dysplasia, most commonly present in the posterior part of maxilla. Classical picture where you will not able to see the cortical outline, ground glass appearance, or thumb impression. There are a lot of appearances of fibrous dysplasia. So here also, if you see, what you have to see, that you always have to compare what is on the left side and what is on the right side. If you compare the bone, zygomatic bone on the right side, there is a slight expansion. So it is a fibrous dysplasia of zygomatic bone as well as zygomatic arch. And this patient, I always remember, so he came in around 2006 or 7. At that time, CBCT was not there in India. And he was complaining that he has some pressure on the eye. And he was complaining that the size of his eye, every day it is decreasing. He was complaining. And we referred it to ENT. ENT said, took some radiographs and he said, absolutely it is fine, there is no problem. But patient is always right when he is complaining something. So after 3 years, in 2010-11, when he came back, then we took a CBCT of that patient. And in CBCT, I didn't notice anything. Your eyes sees what your mind knows. So when I'm reporting my cases, when I'm diagnosing my cases, I always review it second time. So second time I noticed something, that is fibrous dysplasia of ethmoidal bone. Fibrous dysplasia of ethmoidal bone, and patient was absolutely right. He was subjected for psychiatric, he was subjected to ophthalmology, but nobody has diagnosed. That he was very right about his problem, that his size of his eye is shrinking. The reason was the fibrous dysplasia of ethmoidal bone, which is causing pressure on the orbit. That is first and last case of cherubism which I have seen in my practice, a classical appearance of cherubism. So this case I want to discuss, that is very common finding if you have CBCT data, and this is called a cemento-osseous dysplasia. So I have multiple cases with a follow-up of more than 10 years. It is dormant, it is not going to cause any problem with the patient. The only thing you have to remember always, that whenever cemento-osseous dysplasia is present, you have to take care of that teeth. Because if there is a periapical pathology, there are more chances that this lesion will convert into osteomyelitis because of less vascularity. In cemento-osseous dysplasia, they remain dormant. But if there is a periapical pathology, it can convert to osteomyelitis because of the less vascularity in that particular region. you can put implant in cemento-osseous dysplasia lesion, there is no problem. You have to only take care of the vascularity. So cemento-osseous dysplasia, where you have a radiopacity surrounded by a radiolucent halo. Always remember, a radio-opaque, a hyperdense region which is surrounded by a dark circle, it is cemento-osseous dysplasia. So when we call it as cemento-osseous dysplasia, when it is present in the posterior part of mandible or posterior mandibular teeth, but when it is present in the anterior teeth, the same kind of lesion, it is termed as PCOD or periapical cemento-osseous dysplasia. When it is generalized, when it is maxilla is also involved, right and left, mandible is also involved, right and left, then it is called as florid osseous dysplasia. Same disease with the 3 different names on the basis of the location. This is the classical appearance of cemento-osseous dysplasia, if you see. So there is a radio-opaque lesion surrounded by a halo, radiolucent halo, dark circle. So this is normal, need not to be treated. Only have to take care of that particular teeth. There should not be periapical pathology. It can lead to osteomyelitis because of less vascularity. There's a classical case of AOT. AOT, because there is a radiopacity surrounding here. This is classical case of COC. Why COC? Because you can see here these radiopacities. It is not a dentagerous cyst. It appears to be dentagerous cyst, but if you see closely, the crown is surrounded by some radiopacities, small radiopacities. So it is CEOC, central genital granuloma, and that is the classical appearance of squamous cell carcinoma. So this lesion is very easy to diagnose. Anybody can say, okay, this is squamous cell carcinoma. And I'll request you to remember this picture of a squamous cell carcinoma. That this kind of, because I'm going to show you one case where the same kind of lesion is present, but it is not a squamous cell carcinoma. It was something else. So please remember this picture, the kind of destruction what we are seeing here in squamous cell carcinoma. So this patient was complaining of difficulty in chewing on the opposite side, if you see. And the reason was a serious disease of chondrosarcoma. This patient was complaining of difficulty in chewing, difficulty in closing mouth from one side, and the reason was chondrosarcoma of the left condyle. So this, you can see the open bite over here on the left side, and you see the destruction of the condylar head. So this is this is chondrosarcoma. This is a young boy, and again, so we play. CBCT is a gaming tool, so you have to play with the software. So I am going to increase the thickness. So right now it is appearing like a radiolucent lesion, but when I increase the thickness, the volume size, when I increase the bone, then you can be able to see there is something else happening on the downstairs. That is hereon and appearance. That is again a case of osteosarcoma. If you see that, that is a classical picture, OPG of osteosarcoma, when I have increased the thickness. Young child, very young child, because you can see the dentition. It's a mixed dentition. So this is a case of osteosarcoma. Now here, always remember one thing, this picture, you see destruction, but you see bone also. This lady was a doctor, and I told her to get a biopsy done. There was a history of extraction, mobility of tooth, history of extraction, and I requested to go for a biopsy. And she delayed it. And after 3 or 4 months, with this, only this picture, the tissue was where the extraction site was not healing. We took a CBCT, and I saw this destruction in the posterior wall of maxillary sinus. It was a case of squamous cell carcinoma, proven case of squamous cell carcinoma. Later, she has been given the zygomatic implants also. Okay. This young lady, she was complaining of draining sinus, and absolutely no intraoral pathology over here. There is no intraoral pathology, no dental caries, no periapical pathology. OPG was fine, and there was a draining sinus, young child. And we get some investigations done, and it came out to be a tuberculous osteomyelitis. We treated her. So this was the first picture. If you see, there's a destruction on the left side with the coronoid process. The coronoid process is not formed because of the destruction, because of the tuberculosis. And we treated her for 6 months. And this is after 6 months. You see the picture, the coronoid process has been formed here after 6 months of ATT. So tuberculous young child who is coming up with a draining sinus and no intraoral pathology, no parapical pathology, no odontogenic cause, suspect for tuberculosis. It's not that disease is finished or it is not there, it is there. So tuberculous osteomyelitis. This is another case of tuberculous osteomyelitis. So this was the case I was telling. So this was the case where we have a destruction. And if you remember the last picture of squamous cell carcinoma, we have the same kind of destruction in the maxilla. And this case came in 2012 at the starting of my practice. And biopsy, absolutely normal. Nothing came into the biopsy. But I remember this picture because it was undiagnosed case. I was not able to diagnose or comment that what exactly it is. It appears to be a squamous cell carcinoma, but it is not clinically. Again, same kind of case I've seen in 2015, where I have the maxilla was destructed. There's severe destruction in the maxilla. Again, the biopsy came normal, histopath came normal. And again, I got a case in 2016. It is always very, very important to look and to see and to observe the clinical findings. So in third case, after 6 years, I requested my referring doctor that can you send the patient to my clinic? Because from last 4 or 5 years, I'm getting these cases, but I'm not able to diagnose. I want to see and interact with the patient. I saw this patient, the same patient, and I saw these yellow granules. And I learned, what I learned, that all the retrospective cases were actinomycotic osteomyelitis. I learned that this is the appearance of actinomycotic osteomyelitis with the help of this clinical feature of yellow granules. And it was not reported in textbooks or in journals. So how it appears. So actinomycotic osteomyelitis is also very common. So TMJ, like this is a classical case of idiopathic hyperplasia. 3 things patient will initially complain. Patient will say there is a facial asymmetry. You are not able to see the facial symmetry, but he or she is complaining. It is more common in young girls. Second is difficulty in chewing or putting pressure into food. Second complaint. So this is idiopathic hyperplasia of the condylar head. This is subchondral cyst or Ellis cyst, we call it as in degenerative joint disease. So for joint disorders, it is very important tool. It can give you information not about only the condyle, about the glenoid fossa. In temporomandibular joint disorders, particularly if you have ruled out whether it is degenerative joint disease or it is purely articular disease, it will help you. CBCT will help you a lot. So what we see actually in TMJ, we see the outermost cortical line. So if there is breach in the outermost cortical line, it means it is a degenerative joint disease, which is the outcome of intra-articular disorders. So disc displacement with reduction moves to disc displacement without reduction, then move to degenerative joint disease. So it is a natural process to make it disc. Again, back to the, it is a natural process. It destructs the condylar head to make this intra-articular space more so that disc will reduce again. That is a holistic approach for temporomandibular joint disorders. Bifid condyles. Now this is, I've shown you this osteochondroma. Okay. Now this patient was complaining of swelling and pain on the right side. And when we palpated, there was a hard circular kind of thing which we feel. We get an OPG done and it was in the parotid region. And you see this radiopacity, which is circular. what first thing will come into your mind? In my mind, the first thing came it to be a parotid. In parotid gland, there is some salivary gland stone or salolith. It appears to be a salolith. Location-wise, young age patient, history of swelling. Then there is a hard swelling over here. So it appears to be a salolith, purely a salolith. But when we took a CBCT, there is a different picture. It is subchondral osteoma. So your treatment plan, your everything, your treatment plan and your what you are suspecting completely changes once you have a CBCT scan. So when we have a CBCT scan, now we know it is not a salivary gland stone. It is a subchondral osteoma. So this is, so what we have been taught. We have been taught that most of the diseases arise because of the condylar head destruction. There's something which is happening with the condylar head. We never thought what is happening with the glenoid fossa. If you see this case, in the glenoid fossa, you will see the destruction here. Normally, destruction in glenoid fossa, it means it is a serious issue. Okay, so we get, and not always CBCT will help you in temporomandibular joint disorders. So sometimes when you see this destruction in the glenoid fossa, then we subject the patient for MRI, and you see the destruction in this side. Here we have a destruction on this side. Here we see a destruction on the glenoid fossa, which is connecting the middle brain. This was ganglion cyst. This was a ganglion cyst. Not all diseases arise from temporomandibular joint disorders. There are few diseases which are from brain and reflecting into temporomandibular joint disorders as temporomandibular joint disorders. So this was ganglion cyst of the temporomandibular joint with intradural extensions. You see this white ganglion cyst. So I'll finish my lecture with few commandments, 2-3 things, take home messages. First is, thou shalt have sound understanding of order to diagnose disorder. Very important thing. You should be very, very much aware about how the trabecular pattern appears, normal trabecular pattern appears. Then only you can diagnose that this is a case of hyperparathyroidism. Or so normal you have to study, normal you have to read. Second, thou shalt have patience to listen the story of thy patient. Remember, it is the patient who knows much about his problem. Let him speak. So it has been scientifically proven with the help of research that initial question, when you first ask your patient the chief complaint, what is your problem? If you allow your patient to speak more on the initial visit, your prognosis or your diagnosis will become much better. Third, thou shalt have sound understanding of all kinds of radiographic appearances in various pathosis. Remember always that eye sees what mind knows. Thou shalt assess and differentiate your radiograph interpretation before rendering any definitive conclusion in thy report. Thou shalt learn that final diagnosis is a multidisciplinary art. Learn it through your own experiences. Apply wisdom of your master. Always remember that experience is not what happens to a man. It is what a man does with what happens to him. Thou shalt not limit thy approach simply to the use of radiographs. Always try CBCT. Thou shalt know and prevent radiation exposure. Thou shalt always update thyself. And the most important one, thou shalt not be afraid to ask colleague advice. Always remember, interact, because interaction, discussion will always improve your knowledge. I'm so thankful for all of you for inviting me here. Thank you so much. And after Dr. Hemant lecture, we will have a workshop and we will have a personal discussion also. Any question from the audience, if you want to ask, better questions result in better answers. So, any queries? Is there any?
To say that this pathology, that is, you mentioned certain pathologies without clinical scenarios. So I think a lot of people find difficult to say this is that exactly. So if you can describe a little more about it.
Right. What I understand, your question is, I should describe about the pathologies, why I am calling it ameloblastoma. Right, okay. So I'll just 2-3 cases I'll discuss. We'll begin with this case. You see, there's a destruction in the posterior wall. There's a destruction in the posterior wall, but you can be able to see 2-3 simple dots. The bone is still remaining, okay, and the tissue is not healing. There's a history of extraction. The reason was mobility. So this is maxillary sinus carcinoma probably, which has lead to this feature. Now in this particular case, it is a classical appearance. So where you have a hair on end appearance, you have spikes, calcifications of the bone. I'll show you. That is a classical appearance of osteosarcoma. Osteosarcoma means young age, first thing. Second is the classical appearance of hair on end appearance, where you have these flakes coming out from the bone. So that is the classical appearance of osteosarcoma. Even chondrosarcoma also. So these osteosarcomas, chondrosarcomas are more common in younger age group, very younger age group. So you can see these multiple lines, and the OBG also you can see these lines. That is typical of osteosarcoma only. Now here we are not able to define where is the normal bone and where the pathology is started. Where is the abnormal bone? So when you are not able to define a boundary, so that is called as diffuse bone destruction, then it is probably it is a malignancy. If it is not osteomyelitis, either it can be osteomyelitis, either it can be malignancy. But on the basis of clinical history also, because clinical history there must be some exophytic growth, or so then you have to decide that whether it is squamous cell carcinoma or osteomyelitis. So even osteomyelitis also gives same kind of appearance. Central giant cell granuloma, the reason being the patient was young, the site was anterior part. So central giant cell granulomas, they appear in the anterior part of oral cavity, particularly in the premolar region. Always remember, central giant cell granuloma. And you have to differentiate always with Brown's tumor. Whenever a patient comes with a pathology in an anterior part of mandible, right, in the anterior part of mandible, always make sure that GAT and calcium and phosphorus is done. Just to rule out, because in hyperparathyroidism also, there is one disease which is called as Brown's tumor, which also appears, even histopathologically, it appears like central giant cell granuloma. So the 3 diseases which should be always differentiated with, I can talk on pathologies like for a day. So 3 diseases you will always remember, ABC, universal bone cyst, CGCG, and TBC. TBC is simple bone cyst. Okay, so these 3 appear similar, clinically, histopathologically, and radiographically. So we have to differentiate in these 3. Now this is a classical appearance. Why? Because above the crown, there is one more crown, one radiopaque opacities. So it is not a denture cyst, it is CEOC. Then AOT the same. COC appears more common in mandible, AOT appears more common in maxilla. That is why. This I have told you about, reducent halo. Right? Any other question? Any other thing want to ask? Thank you so much. And we will continue after Dr. Hemant's lecture. We will have discussion, one-to-one discussion. Thank you so much.
So, upon that successful completion of the first lecture by Dr. Ajay Parihar, let me now take this opportunity to introduce our second speaker for the day, Dr. Hemant Mathur, a professor and head of the Department of Oral Medicine and Radiology, Pacific Dental College and Hospital, Udaipur, Rajasthan. So, ladies and gentlemen, please put your hands together and welcome Dr. Hemant Mathur. Sir, the stage is yours. Audible. Can you play this? Yeah. This is on the slide share. Okay. Good morning, everybody. I'm Dr. Hemant Mathur. I would like to thank to Candy Dental Society and especially to Dr. Samira and Dr. Thelina for hosting us from last 2 days and by sparing their clinical time. So, I'll give you a brief introduction about my lecture. We will discussing about the digital workflow for the making of the surgical guides. First, we'll giving a stress on the CBCT protocols. If you're sending your patient for a CBCT, and if you're planning a surgical guide in the particular case, what things you need to mention in your requisition form to the CBCT centers, and how to instruct the CBCT guys what things need to be done during the CBCT, taking the CBCT. And we'll go for the designing of the surgical guide. And in the next part, we'll discussing about the 3D printers, the globally available economic 3D printers. I'll tell you, I'm basically a Rajasthani guy. In India, there is a state known as a Rajasthan. And in a Rajasthan also, there is a one community known as a Marwadi. I think you people must be aware of a Marwadi community. That community is mainly a businessman community, and that is a miser community. I belong to that community. I won't explain you about the printers which are high-end printers, very costly printers. I'll focus on the economic printers which are available even in Sri Lanka, and you can use those 3D printers for making a surgical guides in your clinic only. And I'll make it sure by the end of the lecture, out of 100 people, 5 people will definitely purchase a 3D printer. Exclusive company, I'm not promoting this individual company because they are not paying me for this. But I'll promote the economic printer so that you can easily print a surgical guide and you can do the guided implant surgery in your clinics. So I belong to the one of the most beautiful cities in the world, that is Udaipur, the city of lakes. It is similar to Kandy. Yesterday we visited the Kandy one lake, and it is similar to the Udaipur city. And this is my workplace. I've done my post-graduation from this college only, and currently I'm heading the department in the same college. So it is a proud moment for me. It is a Pacific Dental College in Udaipur. And this is my another home, you can say, professional home. This is a Manipal University. And I usually conduct thrice in a year the digital course, and I'm an adjunct faculty in Manipal University for the digital dentistry. This is the first patient named Jacob.
the first guided surgery we have done in 2015. Why I put this picture? Because the Jacob was more excited than the doctors that what kind of a surgery is going to be done with me. Nobody knows about what is the guided surgery. So he insisted me, ki, sir, kindly click the photo and whenever you present the photograph in your any lecture, present my photograph without the hiding my face. So this is the first live guided surgery we have done in AMCOTS, Manipal. This is our all the delegates. And this is a fixed slide in my every presentation since I started delivering the lectures. These are the, we all need someone who inspires us to do the better than what we actually knows. So whatever little bit knowledge I am having regarding a CBCT and a digital dentistry, because of these three professional friends, not a professional, they are family. This is Dr. Mohit Pal Singh. He is a Vice Dean of my university, my mentor, my co-guide. He is Dr. Junaid. He is Associate Dean in AMCOTS. And Dr. Ajay Pariyar, you all must be knowing Dr. Ajay Pariyar. These three people are like, when I started my journey into the imaging part, I was not having a knowledge. I was not having a money. I was just having a zeal. So they are the people who said, Kidnana, go for it. Go for it. Whatever happens, we'll take care of it. Whether it is a financial loss or whether it is an emotional loss or whether it is a professional loss. So I am proud to have these three friends. And this is my team. Young team. I can see many young dentists are sitting over there. Digital dentistry is basically a video game, I'll tell you. PS5, Xbox. As Ajay sir said, it is these are the softwares. You need to play with these softwares. So I have a very young team, Dr. Sneha, Dr. Chitrangsha, Dr. Isha and Dr. Akansha. I am not only working, this is my team, they are working with me. And he's one of the best friend of mine. He is always there for me, everywhere. So I hope you can understand what is written in a Sinhalese language. Ki bhai, next center is on the Fifi Island. Next CBCT center is on Fifi Island. Everywhere where me and Ajay sir goes, we look for business plans. Every city, every country. Ki we can put a CBCT center over there. So, and he's my son. Why I put his photograph? Because when I enter into a 3D printing, I usually do the 3D printing late nights after 10 or 11 o'clock, because before that I was at my centers, and 3D printing needs a lot of time. So he always be with me, but only at one cost. After printing any surgical guide, you have to print one car for me. So this is every time I have to print this. So let's come to the topic. We'll discuss about the digital workflow, and it is basically an art to print your plans. Whatever you are thinking, whatever is in your mind, what to print. Before starting, dentistry is changing every day. Every day, the new cements are coming, new impression techniques are coming, new machines are coming. So if you are not changing with the time, that will be not good for a practice. Believe me, I can see there in a trade fair, they are having alginates and the stones, dye stones. Believe me, by 2030, just keep one alginate packet along with you. They are going to obsolete. You will show after 20 years to the new generation ki this is a kind of a material which we are using to take impressions. Intraoral scanners are capturing the international market. I remember 5 years back, intraoral scanner costing Indian currency 15 lakh rupees. 15 lakh rupees. And they are not ready to bargain on it. But now the intraoral scanners are, you can get in a 3 lakh rupees Indian currency. So once the intraoral scanners are into the market, the total digital workflow is there. Whether You talk about endodontics or implants or even for a periosurgeries, guided periosurgeries. So you have to change your clinical practice. This is Mumbai city, I think many of you know. Mumbai city, this is 1980s and this is 2025. Another biggest example, if you're not changing, I think nobody is having a Nokia phone over here. Anybody is having Nokia phone? No. 10 years back, everybody is having a Nokia phones. One of the best phone was 3310. The snake and ladder was there, snake game was there. Nokia is not changed, they are not changed themselves, that is, they are out of the market. And I think everybody is having iPhones over here because they are changing every year, whether it is a camera or anything. So let's go to the subject. For a surgical guide planning, for an implant planning, what you want to know if you're getting a CBCT or a OPG done? You just need to know what is the height, residual height of the bone, and the buccolingual and a mesiodistal dimension. Agreed? Everything is, the 3D thing is having a 3 axes, X, Y, and Z. X and Y axis you can appreciate in a OPG. The height and the width, mesiodistal dimension. But you cannot appreciate a buccolingual or a buccopalatal width. That is a main concern while doing this surgical guide planning or implant surgeries. So for a good planning, you need to know all the 3 axes, X, Y, and a Z, especially the Z axis, how much amount of a buccolingual or buccopalatal width is there. As well as there are n number of morphological alteration in a alveolar bone you can appreciate. N number of morphological alterations. So only through the CBCT you can come to know the alteration in a morphology. See this case. This is a fantastic case. This is a reconstructed image of a CBCT, 2D image. I can see can you appreciate the canal in this case? I can appreciate this is a canal, inferior alveolar canal. I think everybody can appreciate this. And this height, if I calculate in a 2D image, it will come around 14 to 15 millimeter height. Fair enough, good case. Fantastic case. I'll go directly, give an incision and place an implant. Fair enough case. But what's there in a see? There is a bayonet shape or a moderate labial and a lingual concavity. This is going to the disaster if you are going without a CBCT or a 3D imaging. Can you see this labial concavity? This is a bayonet shape. We'll follow the long axis, the x-axis, and we might end up with the perforation of a lingual cortex, and especially on the buccal cortex also. So, hello. We need to know the critical anatomy of the alveolar bone and the adjacent anatomy of the implant sites, especially the vital structures. Vital structures in a mandible, it can be a mental foramen, inferior alveolar nerve, and especially in the anterior region, mandibular anterior region, that is a median lingual canal, which we might ignore during the implant planning. And in maxilla, the maxillary sinus and the nasal cortex, nasal floor. And the quantity and the quality of a bone is very important. What kind of a trabecular pattern we are having. Okay. We might see this kind of the knife edge ridge, depressed crest, and the atrophied bony anatomy. This is important. Can you see this lingual undercut? Here, this is a lingual undercut. If through the 2D imaging, if we are going, we follow the long axis and we perforate the lingual cortex and in this kind of a knife edge ridge. If you are going for an implant surgery, freehand surgeries, definitely your initial osteotomy drill might slip because it is having a knife edge ridge and this ridge angulations. So come to the guided implant surgeries. Hello. Hello. One of the initial thing what we do wrong during the implant surgery, that is the locating the initial osteotomy site. If you are wrong at the initial osteotomy site, your whole surgery goes wrong. Agreed? If the initial osteotomy site is wrong, then you'll carry the wrong path. So to avoid that kind of a mistake, the guided surgeries are best. And second thing is, it should be restoratively planned. The patient is coming to you not for the implant. That is your treatment plan. Patient chief complaint is replacement of a missing tooth. Patient is least bother what you are doing. If you convince the patient for the treatment, after that he is least bother what you are doing, what kind of impression, what kind of a material you are using, what procedure you are doing. But patient's chief complaint should be resolved. Agreed? So if you are placing an implant without prosthetically driven, without a relationship with the antagonist tooth, then your surgeries, then the final outcome is going to be wrong. Okay, this is one of the pictorial example. We'll do the surgeries, implant surgery, we'll place the implant, but at the time of the prosthesis, we'll find we have to give a custom abutment of a 30 degree, 40 degree, 60 degree, and the patient come up to you after 1 month, I'm having a pain in this side. Then there will be you're going for accurate arch, everything. Okay, these kind of a problems occurs because of the wrong prosthetic parts. So we can resolve these problems if we are going through the guided surgeries. So in this lecture, we are covering to understand the digital workflow, designing of the surgical guide. I'll give you the demo of one case. We'll design one surgical guide. Of that particular case, models I have already bought from India, and the surgical guide also. The same case we'll design and we'll print and fabricate that particular guide here only. Okay, by the end of this session, means during the session we'll go with the printing part. And how to use the 3D printers, most important. If you purchase a 3D printer, not an issue. Maintaining a 3D printer, and there are n number of issues you can have with the 3D printers while printing. Okay, so we'll discuss about the 3D printers and how to handle the surgical guide complications during the surgery. So the best way is to do the implant surgery. Totally prosthetically driven implant should be placed. If you are having a surgical guide, during your surgery, since starting from placing the surgical guide into the patient mouth until the implant is placed in the patient mouth, that is known as a total guided implant surgery. My request is, whenever you are doing the implant surgeries, guided implant surgeries, don't remove the surgical guide after your drilling is complete. Always place an ideal guide is that which will place the implant into the patient mouth through the stent. Don't remove your surgical guide before placing the implant. This is my personal experience I have seen, because if you remove the surgical guide and you place the implant, then also you might follow the wrong pathway. Okay. Then the last thing is, these guided surgeries are more predictable, but I'll tell you, it is not an alternative of a freehand surgeries. Many surgeons are sitting over here. So I'm not saying that always go for a guided surgery. No, there is no comparison of a freehand surgery. If you are having a good surgical skills, guided surgery cannot replace that. Okay, and if we talk about a profit in-house, if you are having a software, you are having a 3D printer, definitely it is profitable job. You might end up with saving a lot of money. If you are only designing, you are only printing the surgical guide, because surgical guide costing around 2,000 to 3,000 rupees for a single unit surgical guide. if you are getting it done from anywhere, any lab, they are charging, in India, they are charging in between 2000 to 3000 rupees for a single unit guide. If the implants add on, then they'll charge 700 rupees for a individual implant. So if you are going for a all on 6 or a all on 4 course cases, the maxilla and mandible will end up with a 7 to 8,000 rupees. So if you are doing in-house, it is profitable job, definitely. So the guided surgeries are not 100% accurate. This I'll tell you, these are not 100% not accurate. They are precise and they are predictable. If anybody is saying ki I have planned, I have done the guided surgeries and they are 100% accurate, the place where I have planned, it is exactly on that particular site, that is wrong. There will be a deviation, 100% there will be a deviation of 2 or 3 mm apically or 2 or 3 mm at the crestal level. And guided surgery is not for every case. Don't think in every case you can go for a guided surgeries. No, not for every case guided surgery is indicated. So whether to guide or not to guide, this is a question for me. I always ask to me whether to guide this case or not. So after having an experience of 10 years, I first decide, I don't see the case. I first see who the doctor is doing the case. I'll choose the doctor, because it is not like guided surgery is not a magic. One fine day you come up to me and you said, sir, I want to do one implant guided surgery. The person, again I'm saying, it is not an alternative for a the surgical hand. You need to have a knowledge about the implant surgery, only then go for a guided surgeries. You should have an initial experience of making the incision, drilling. You have to feel that tactile sensation while you are drilling the bone. It is not for beginners. To be very frank, it is not for beginners, those who have never attempted any implant surgeries. It is definitely the less time you will take in a guided implant surgery. It is easier, comfortable for the patients. So the type of guided surgeries, initially 10 to 15 years back, what we used to do as a guided surgery, we make a template, we took an impression, make a cast, and above the cast we'll make a acrylic stent with a cold cure or a heat cure. We'll make a stent and we'll at the crest of the cast we'll point where is our osteotomy site. That was the initial, I think 10 to 15 years back we used to do this. But in this type of a conventional guided surgeries, the clinician can only decide the initial osteotomy site at the crest, only the initial osteotomy site at the crest, not below the crest. So this is a case in our college only. Initially during my PG time they have take a cast, make an impression, then they pour the cast, and simple RPD procedure they have done. And can you see this template they have made? Fantastic case. Fair enough, it is a good case. But when we took a CBCT, this is totally a perforation of a bone. So the disadvantages of the freehand surgeries, first is all the mistakes are catastrophic, like initial osteotomy site is wrong, angulation is wrong, and especially in cases of anterior maxillary anterior region, you might end up with the laceration of a soft tissue. That also leads to the failure of the cases. So let's come to the guided surgeries. This is very important slide. What all you need for a guided surgeries? You need a CBCT. CBCT means good CBCT. I'll tell you about what kind of a CBCT you need for a guided surgeries. Then you need a STL file. We'll discuss about all these. If anybody is having any doubt regarding any technical word, please ask me if you are not accustomed to these words. CBCT DICOM files, STL file you need. Then most important is a planning software. You need to have a planning software. The machine which you are having, CBCT machines, they are not having a planning software. Planning softwares are different. Guided planning softwares are different. Okay. They are paid softwares. I'll tell you about the softwares also. And once you are having a DICOM data and a STL file, you need a planning software. And once the planning is done, you can go into the 3D printer for the fabrication of a guide. So the checklist for the guided surgeries, very important, CBCT. Suppose if you have, the most important is before going for a planning, check when the CBCT was done. Suppose if a patient is coming to me with a DICOM volume and a CD, Dr. Saab, I want to go for a guided surgery, for an implant surgery in my right posterior region. And many doctors do this mistake. They just see the DICOM data. Yeah, we can go for a implant surgery with this CBCT. But according to the different school of thought, after every 3 to 6 months, the oral environment and the oral flora changed. Suppose if a patient is coming to you with a missing 4-6 and 6 months back CBCT was done. Suppose after 3 months he is having a periodontal abscess or any sort of a swelling that might hinder in a final outcome of your surgical guide fabrication and your net outcome of the implant placement. Because the oral environment is different and 6 months back, and after 6 months the conditions are changed. Then the FOV. Always go for, suppose if you are going for a single unit implant also, go for either for a maxilla or a mandible. Don't go for a smaller FOV. 5 by 5 FOV. Don't go for 5 by 5 FOV. Only go for a diagnostic purpose. If you are having an endo case or a single unit implant for your purpose only, then only go for a small FOV. If you are planning for a one implant in a mandible, always go for a full arch. Don't go for a full mouth. Always go for a full arch, like 8 into 5 FOV. Minimal 8 into 5 FOV. Why I am saying this? The longer your guide is, the longer the extension of your guide is, more stable your guide. If your guide is small, it will have a chances of a deviation. It will deviate. There is a tapping of a surgical guide. So go for a large FOV. Minimal 8 by 5 or 5 by 10 FOV. More the extension of the guides, more the stability. Then if your CBCT is having any sort of a artifact, most common artifact in CBCT which will usually come across is the patient moves during the scanning part. And you can see this kind of a double image in a CBCT. If planning on this kind of a CBCT DICOM data, your final outcome is going to be disastrous. Your surgery is going to be fail. Because the software will capture first this image, which is not an actual image, this movement image. Can you see this double image? The software will capture this. So intraorally, this is not actually a site. Then if patient is having a n number of PFM crowns or n number of amalgam restorations, this will give this metal artifact and the beam hardening artifact. Now you say, sir, you are saying don't go for this CBCT also, and the patient is not ready to remove the PFM crowns before the implant surgery. The patient will say, no, first do the surgery, plan the surgery, then I'll remove this PFM crowns. So I'll tell you how to rectify this artifact in the next few slides. If the patient is having a n number of a PFM crowns, because the PFM crown will create a artifact, metal artifact. Okay. Beam hardening. This is out of my lecture. If you are placed an implant, don't go for a post-implant CBCT assessment. there is a n number of a reason, not the jokes apart, because CBC, after having a CBCT, post implant CBCT, every radiologist, I usually talk to the doctor first, should I report it? Because now patients are passing out from the Google Medical College. They'll correlate, they'll type everything in a Google and they'll ask what it is written. Peri-implantitis, it means implant is failed. I've seen the doctors are calling me, don't write anything on the report. So first is, for the post implant, you cannot appreciate a fracture implant. It is very difficult to appreciate a fracture. If the head of the implant is fractured, that is a different thing. But apical end or at the middle 1/3 level, if a micro fracture in implant, you cannot appreciate. Best diagnostic tool for appreciating the fracture of the implant is RVG. Gold standard, still it is a, IOPA is still a gold standard radiograph. Good RVG is a gold standard radiograph. Because you'll see in every case, there is a peri-implantitis or a bone loss. And your heart will sink after seeing the CBCT. So don't go for a post-operative cases. Don't use these kind of CBCTs. Proper positioning is not an issue nowadays in any CBCT machine. You need not to have any knowledge. Anybody can position a patient in a CBCT machines. They are so high-end machines. You just tell to the patient, just sit here or stand here, just bite on this block. Machine automatically adjusts the patient position. So these are the old book theories. So requirements, you need a DICOM file. For any guided surgery, you need a DICOM file. From where you will get a DICOM file? First is from the CBCT machine. Suppose if in your place, somebody might be from the another small town or the places where CBCT machines are not there. The another option to get a CBCT is get a CT done. Plain CT scan. I think CT scan machines must be there in a Kandy or a nearby. Every diagnostic center is having, medical colleges are having CT machine. So either get a CBCT or a normal CT done, multi-director CT can work in a digital surgeries. This is very important slide. If you are getting a CBCT done for a patient for a guided surgeries, make it sure that patient will bite on the bite block. It should not be in a intercuspal relationship. Why? You can see these two images. There is a gap. There is a radiolucency, frank radiolucency. This is a tongue and this is a palate. Our guide need to be placed somewhere. It will definitely rest on some soft tissue. If the soft tissue merges, like in a first image, you are not able to create your guide. So while CBCT, instruct the CBCT guy to make the CBCT done in a bite position. 100% there should be a bite. Now the another question is, sir, what if the patient is completely edentulous? Agreed? If a completely edentulous patient cannot bite on a bite block, then what you need to do is use a cotton rolls, make a cotton rolls and let him bite bilaterally on the right and left side and then tell him to bite. Okay, this will give you the separation between a upper and lower arch and the differentiation between the hard tissue and a soft tissue. What kind of a CBCT we actually DICOM file we want? It should be ideal, without any artifact, without patient movement, nothing. STL file, another very important if you are going for a guided surgery. First, you need a DICOM file. DICOM file can be arranged from a CBCT or a multi-director CT. Then it comes to the STL file. STL file is a printable file. Anything if you want to print through the 3D printer, that file format should be STL in this kind of a printer. STL, stereolithographic files. Okay. So from where you'll get a STL files? Intraoral scanner. From intraoral scanner, you will get a STL files. Easy job. Just call a patient, use an intraoral scanner and scan. Now you'll ask, sir, we are not having an intraoral scanner. It is a costly affair. Intraoral scanners, I think here it is costing 5 to 10 lakh rupees. Intraoral scanner, not everybody is having an intraoral scanner at their clinic. Now you will ask, sir, now we can't do the guided surgery. You can do the guided surgery. How? Take an impression, good putty impression, rubber base impression of a patient. Suppose if you are going for a 3/6 implant, 3/6 or a 4/6, take a good impression, good impression. I'm insisting good impression. Okay. Make a cast and send that cast to CBCT center. Along with the patient, scan this cast also. First scan the patient and scan that cast. Or another option is a desktop scanner. It is also a costly affair. Only the labs are having. We are not having a desktop scanners at our clinics. Only the labs are having. So best is to get, if you are not having a intraoral scanner, desktop scanners, make a cast, scan on a CBCT machine. Can you see this? The machine is scanning. But now the another question is, whenever you put a cast on a CBCT machine and you click on there are two options are there, scan a patient or scan a cast. When you click on the scan a cast, the one window will pop up on your screen. And it is saying that the software you need to upgrade. When you click on the upgrade, they will ask, contact your trophy DICOM dealer for the subscription. And that subscription is, Mr. Shiva will tell, he's a K-stream guy who is sitting over there, what is the subscription for the STL conversion. It is costing around more than 3 to 4 lakh rupees. As I told you at the starting of my lecture, that I am a Marwadi. I don't waste money even still I am not having a subscription for Spotify, which is 1 rupees in a day. When it is freely available, why to spend the money? So, don't go for a subscription. Don't go for a subscription. Don't click on the scan cast. Click on the scan patient. You will get a DICOM file. Anything which is the machine is scanning, it will give a DICOM file. Okay. Once you get a DICOM file of this cast, then the CBCT role ends. Then import all these patient cast, patient DICOM file and patient cast into the planning software. Planning software automatically convert into the STL. Got it? So first we need a CBCT DICOM data. CBCT DICOM data can be arranged from a CBCT machine or through the multi-detector CT. Then we need a STL file. STL file can be arranged from a intraoral scanner or desktop scanner. If you are not having the desktop and intraoral scanner, make a cast, get it on the CBCT center and scan that. Without scanning, without clicking on the patient scanning. Just click on the patient scanning only. No need for any subscription. So we are having the DICOM file and a STL file. Now the picture comes for a planning software. I am a huge fan of a cricket. I am also a good cricketer, and he's my favorite player. Mahendra Singh Dhoni, our previous captain. I hope everybody remembers the shot. He's a game changer, and he's a most trustable man which we consider in a cricket. And in Sri Lanka, he's my favorite cricketer because these and the Virat Kohli, these are the more reliable. Whenever they are on the crease, everybody is like chill. They'll took up the game. Whether it is a Sangakkara or our King Virat Kohli. Same with the planning softwares. There are n number of software, but the best software is a ExoCAD. Why I am saying ExoCAD? It is most reliable software because this is the only CAD software which is having a official implant libraries of approx 500 implant companies. official implant libraries. And it is very easy. I'll give you the demo. Within a 4 to 5 clicks, you can design a surgical guide in this software. Within 4 or 5 clicks, if you are having a DICOM file and a STL file. This is very important slide. These are the available softwares. You can see there are on my right side, the yellow software, written in a yellow software, and another is in a blue corner. There is a difference. The softwares which are in a yellow font, they are free software available on a Google. You just have to type download Slicer, download Blinder, download Radiant, download Blue Sky, download ITK Snap. Freely available, you can download in your laptops and you can start planning the surgical guide. Okay, and the softwares which are in a blue corner, they are paid softwares. You need to have a subscription for these softwares. Done? So, this is one of the fantastic software, Blue Sky Bio. Just a 30 MB software you can download from Google, and it will give you the 7 conversions free. 7 conversions free. You can plan a 7 cases once you download it. 7 cases you can plan free of cost in Blue Sky Bio. But after this 7 case, on the 8th case, they will ask you for the subscription. For a single conversion, they are charging 25 euros for a single conversion. 25 euros, huge amount. But nahi dene ka, we need not to give the 20 euros. Now what to do? If you again reinstall this software, they will capture your IP address and they will again charge you. Now what to do? The young people who are sitting over there, what to do? Tell me. If I want to hide something in my Google history, if I want nobody can see my Google history, search engine, what I have to do? Tell me. Sorry, sir? Yes. There is one option, incognito. Have you used incognito? Yes, everybody have used, I know. So, to open a window in an incognito, download Blue Sky Bio again and start working. Again, the 7 case will come up. It will show the 7 credit points you are having. So once you are again and again download in an incognito and you can work free of cost in a Blue Sky Bio. I hope this recording is not going to the Blue Sky Bio people. Whatever I'll discuss in my lecture, it is just through my personal experience. And the cases which I'm showing, there's no Googled. Every cases is done by us only. And these are the personal experience which after having, because these planning softwares are very costly. Very costly. 5 to 6 lakh rupees per annum subscription. So this is very costly. The countries like our Asian countries, it is very difficult to afford such kind of a software because patients are not paying so much of amount to us. So, another very important slide. This is a very important slide. Whenever you are getting a CBCT data from your center, suppose if your center is sending, you said, send me the DICOM file on my mail. If they send you, these files will be around 500 to 600 MB. The file size is 500 to 600 MB. So, they have to send it through the Google Mail or Google Drive. And if I'm sending anything through the Google Drive, it have to be zipped in a compressed format. Such a long file is there. So once the compressed file is sent, you can see the zip, it is written over there. It is a zip file. Zip file. Zip file means it is a compressed file. In a one folder, it is compressed. So once we directly click on that folder, and you will say, sir, software is not opening because you have clicked on the compressed folder. What you need to do is you need to uncompress the particular folder. But there is also an issue. When we purchase a laptop, we are doing for a 1 year, we'll do everything on the laptop. Then after 1 year, Microsoft will ask you, you need to subscribe for the Windows and for the PPT and a Word file and for the this WinRAR software. But we are not subscribing it. What to do? Download a software, another software that is named 7-zip. It is a 2 MB software. Within a fraction of a second, it got downloaded, 7-zip. So always unzip your DICOM file and STL file through this 7-zip. Free software. Then what you need for a fabrication, that is a 3D printer you need for a fabrication. 3D printing can be done through the 3D printer and through the CAD machines. The CAD machines. Both are different. CAD machines and a 3D printer, there is a huge difference between a CAD and a 3D printer. So why computer guided surgeries? Advantage, it will decrease the manual error associated with the freehand surgeries, that is like initial osteotomy site and the angulations. Second is to avoid the wrong orientation drill and the minimal damage to a soft tissue. Believe me, this last line, the soft tissue. My wife is a periodontist, and before entering into the surgical guide planning, I always make a fun of a perio branch. Ki you people create a big issue on a small tissue. There is nothing in a periodontium. But believe me, 90% of the the implant surgeries fail due to the manhandling of the soft tissue. While doing the surgery, we'll put the incision and we don't think about the soft tissue, resuturing and everything. But believe me, if you tackle the soft tissue very precisely with a soft hand, your outcome will be fantastic if the gingiva is properly restored. So minimal, in a guided surgery, there is a minimal soft tissue damage. Just a 3.5 millimeter of a diameter tissue punch is there. If you are going for a, whether a all on 6 case, all on 4 case or a single unit, you need to punch 3.5 millimeter diameter on a soft tissue only. No bleeding will be there. So there will be a minimal soft tissue damage. Another advantage, you can plan the prosthesis before the surgery along with the antagonist. This is one of the biggest advantage of the guided surgeries. And the ultimate goal of a implant surgery is to maintain the parallelism. I remember the Dr. Mesh. He passed away 5 to 6 years back. He is the father of implantology. He always, in his book, the main focus is on the maintain the parallelism between the implants or maintain the parallelism between the implant and the adjacent teeth. That is an ideal protocol for the implant surgeries. But nowadays, I don't know about the Sri Lanka. In India, the people are going for a not for a conventional implants, we are going for a basal cortical and the zygoma implants. Nobody is thinking about the parallelism because they are more focused on, I can place an implant anywhere and I can use a custom abutment. 30, 60, 40 degree, 65 degree. Now the maximum custom abutment can be given of a 65 to 70 degree. People are giving. But the outcome, the longer outcome is not good if you are giving a 60 or a 70 degree angulated abutment. So while planning the implant, it should be parallel. If you are planning one implant, it should be parallel to the adjacent teeth. Or if you are planning all on 6, all on 4, make it sure that they are parallel. There is more longevity for that particular case if the implants are placed in a parallel orientation. I'll give you an example. And another is flapless surgery. It is totally flapless. No incision. No incision, just a tissue punch. See, just a tissue punches. And in a guided implant surgeries, you can maintain the biomechanics. Evenly spread the implants on the bilateral sides and even in the anterior region. This is most important for the stability of the prosthesis. If you are placing all on 4 or all on 6 case, your ultimate goal should be your denture or your prosthesis should be stable. It is not like this. This I think many of you have seen this movie, Hrithik Roshan, Koi Mil Gaya. The song is Idhar Chala Main Udhar Chala, this side or this side. You don't want a denture or your prosthesis to be like this, or you don't want your prosthesis to be like this. I think many of you know this. These two guys, these are the famous actors in India, Amitabh Bachchan. Nobody want the prosthesis like this. Denture is going up and down. Everybody want a prosthesis like this. This is another famous picture in India. Ajay Devgan, I think you have seen him. This is his first movie, and he's famous for this particular scene. Now, my question is, Ajay Devgan is not playing any vital role in this. The role is of these two bikers. They are running with a constant speed at the same distance. That's why Ajay Devgan is stable. Jokes apart, this is basically in an implant. If the implants are parallel in a jaw, your prosthesis will be stable. This is a case, recent case I have done. This is a completely edentulous case. And we have done this, the guide is fabricated, the punches were used, tissue punches. See, this is a complete parallelism. AP spread is fantastic. Implants are placed at even distances. And I always make it sure, for my purpose, post-op, if a guided surgery is done, then post-op CBCT I'll definitely do. People will put on, take an OPG and put it like we have done such or such cases. OPG will give you a false image. If I can reconstruct this in this OPG pan image, you never know whether it is a labially perforated or a lingually perforated. That's why I always put this axial sections. The implants are well within the osseous confine. And this is a completely parallelism was maintained. And the another advantage, you can maintain the proper width, height. You can decide the height and the width of the implants. And the minimal risk to perforate the vital structures. In implants, guided implant surgeries, there are minimal risk until unless if a person who is designing the guide or the clinician made a blunder, only then you will perforate the vital structures. Otherwise, you are not supposed to even touch the outer cortex of the vital structures. You can prefabricate the prosthesis and abutment before going for a surgery, because nowadays patients won't do it now. They are coming from some other countries and they want, I am here only for a 5 or 6 days. Make it sure you do it now. In a guided surgeries, you can plan your surgical guide and your plan your prosthesis. Along at the day of the surgery, you can do the immediate loading. There are few limitations of a guided surgeries. First is you need a specific kit and a drilling protocol. I don't know which implant company here you people are using. There are few common companies like Edin, Dentium, Ostium. All the companies are having their specific guided kits. If you are having a guided kit, the normal kit, implant kit is known as a taper kit. These kits are not having the stoppers. Your drill can go anywhere at any length. But in a guided kits, they are having a stopper at the offset part. You can't go beyond that. So all the implant companies are having their own specific guided kit. But there's one famous company that is, I won't quote the name. They claim that our implant can be placed through our guided kit only. So it is not possible for everybody to purchase every guided kit. Guided kits are very costly. They are in between a range of 1 to 1.5 lakh rupees. So for everybody, it is not possible to purchase a guided kit. So we have customized the kit and the few things through which you can place any implant, whether it is a Edent, Dentium, Dionavi, Ostium, Noble Biocare. I'll show you the kit. I am having a one kit, Ostium one guide kit. You can place any implant through that kit, any implant, whether it is an Israeli implant or whether it is a Korean implant. Yes, I'll make it sure that you just plan the case and I'll send you the kit and you do the surgery. Any implant company. So this is a specific kit you need, and implant, once, suppose if I'm making an implant guide for you, after planning, I'll send you the report. Such residual bone is remaining, and I have planned for 4 into 11.5 implant diameter and a length. After deciding, once you approve that planning, you cannot change because in my inventory I am having 13 length of implant and 3.5 length implant. Can we go for that particular length and a width? No, you can't go. Once the guide is fabricated, because it is totally a digital guide, the height and width will be decided by us and a software. Once it is fabricated, you can't go beyond or you can't go the lesser than that particular height. So once it is decided, you cannot change the implant planning. Second is, during the implant surgery, position cannot be changed. If you want, during the surgery, half initial osteotomy side, you say, I want to change the angulation. No. Then you have to remove the guide and you do the freehand surgeries. Another, one of the biggest disadvantage of a guided surgery is there is a lack of irrigation. If during any surgical process, if there is no irrigation, that leads to the necrosis of that particular part. Guided surgery, because the drills are, there is no space in between the guide and a drill, you cannot go with a irrigation part. So this is one of the biggest disadvantage of the guided surgery. But we have come up with another modification. We have placed another hole in a surgical guide through which you can place that physio dispenser irrigation part. So we are on the working mode. We have come up with a prototype of that, and in coming future we'll definitely recover that particular disadvantage of irrigation. Then an ill-fitting guides. This is my advice to everybody. If you are getting a surgical guide printed from anywhere, if that guide is not snugly fitted, if there is any sort of a tapping, you remember in a prostho UG labs, we are going for that base plate adaptation. For a dentures, we go for a base plate. If there's any tapping, the professor come and he'll crack that particular base plate, and again you have to go for a full procedure. If there's any tapping, suppose if it is tapping, means your surgical guide is wrong. Don't use that surgical guide. It should be snugly fitted. I'll show you the surgical guide. See this. Madam, just pass on after seeing this. Your surgical guide should be snugly fitted. There is no sort of a movement. If there is a movement, just cancel the case. Then this is the question asked by me during my initial journey. How accurate is your guide? Guide is not 100% accurate. It is precise and predictable outcomes. There's a difference between accuracy and preciseness. Accuracy means if I'm hitting a particular point on a bullseye continuously, if I try 10 times and I'll continuously hit on a bullseye, it is accuracy. But if I'm hitting nearby to the bullseye for a 10 times. That is known as a accuracy. So guided surgeries are precise, not accurate. So according to the meta-analysis of a guided surgeries, there will be a deviation of 1.5 to 3 ml. So tips and techniques for the guided surgeries. There are types of guided surgery. First is tissue supported. Tissue supported means the guide which is resting totally on the mucosa, soft tissue. Another one is tooth and tissue supported. The guide which I have given you, that is tooth and tissue supported. The one part of a guide is resting on the tooth and another part is resting on the tissue. And this is high-end bone supported surgical guides. I am not going to talk about this because these are the high-end surgical guides. In cases of a knife edge and a completely resorbed ridges, we are going for the bone level guides. This need a whole day to explain the bone level guides. So these are the, first is pilot guide, tooth supported, mucosa supported and a bone supported. So we'll going for a individual case, the completely edentulous case, partially edentulous case and partially edentulous cases with a metal prosthesis and number of prostheses of patient is having. So first is a pilot surgery or a semi-guided surgery. Another is a fully guided surgery. Semi-guided surgeries is like completely guided surgery means we can decide the height, width of the implant and we'll place the implant through the surgical guide only. That is a fully guided. Everything is planned by the software. Okay. In a semi-guided surgeries, you can only control the initial osteotomy site and the initial angulation. There is a small, in a implant kit, you can see there is a pilot drill. One pilot drill is there, very, very thin and a sharp drill. That is known as a pilot drill. Will give you the very small hole of a diameter of 2.3 millimeter, maximum 2.3 millimeter, and the only a single drill will be there. The doctor will drill and he'll get an initial osteotomy site and a path for the another surgical drills, and the guide will be removed. Then only after getting an initial site, you can remove the surgical guide and go for a implant surgery freehand. In which conditions you should go for a semi-guided surgeries, especially in a maxillary anterior region, aesthetic zone, because in an aesthetic zone there is a thin gingiva, and in those cases in which GBR need to be done, GBR or PRP procedures need to be done. In those cases in which you have to raise the flap because of the thin biotype. Okay. See, in this case there is a thin biotype. We have raised the flap, done the GBR, and before that we have chosen the initial osteotomy site through the single drill. This we have customized the sleeves. If you are not having a guided kit, you are having a normal implant kit, surgical kit along with you. We have customized these sleeves. Can you see the diameter written over the 2.6, 2.9, 3.3, 3.4? These are the diameters of a universal diameter of every implant company. Normal drill kit. You can use this, these are known as spoons. You can place the surgical guide in a patient mouth and use these sleeves and drill through the your normal implant surgical kit. This is a basic protocol. You just place the surgical guide in a patient mouth, use these drills and continue within normal implant kit. Only a single drill need to be done. See, this is a case we have done. This is a conventional semi-pilot guided surgery. See, The implant looks perfect. But after having a post-op CT, I can appreciate I can go more palatally. More palatally can be done. So in the next case, we gone for the completely guided surgery. This is a bone. This is a complete guided surgery. See, this is a guided kit we are using, completely guided kit. See, in this, there is a stopper in this kit. Your drill cannot go beyond your surgical guide. It is pre-decided by the software that only 10 mm of the drill should go. It will stop at the 10 mm only. Then the GBR was done in this case. See, this implant is in within the centrally within the bony confines. Then biggest disadvantage of these spoons which I have shown you, these spoons, biggest disadvantage of these spoons, if during the guided surgery, if anything is moving, whether the surgical hand is moving a lot, whether a surgical guide is moving, or any attachment is moving, that will change your outcome, net result outcome. Disadvantage with these spoons are, see, can you see there is a movement? If I am a surgeon, I can hold a physio dispenser erotor and I hold this surgical guide. My auxiliary staff have to hold this. If there is any sort of a movement in this spoon, my initial osteotomy site will go in the another way. So that can lead to the failure of the cases. This is a fully guided surgery. I have a surgical kit. After the lecture, in a demo session, we'll show you the surgical guide kit. This is a fully guided surgery cases. In fully guided surgery, in a software, we will decide the initial osteotomy site, what is going to be the length of the implant, what is the width of the implant, and what is the angulation of the implant in relation to the antagonist. Everything is decided by the software and it is fully guided implant surgery. You can use in a tooth supported guides also. So again, what you need for a surgical guide? For a tooth supported, you need a plain STL and a DICOM data. Intraoral scan, desktop scanner, or through the cast scanning. What if patient is having a multiple number of a metal prosthesis in his oral cavity? This will gives you the artifact, metal artifact in a DICOM data. To overcome that particular metal artifact, what you need to do is just make a 5 mm diameter composite balls. Don't use GP and don't use metal balls. Use composite. 5 mm diameter composite balls and just place on the adjacent teeth on which there is no PFM crown. If all the teeth are having a PFM crown, then place at least at the 3 places as far as possible. Suppose you place one on this right central incisor, another is on the 1/6 molar, and third one is on the left side of the molar. Minimum three markers need to be placed. Minimum. Remember this word, minimum 3. Why 3? Because as we were talking about the 3D only, minimum 3 static markers need to be there. You can place 6 or 7 also, but minimum 3 static markers should be there. So for the tooth supported, this is a STL file. This is a file the cast which you have, you took an impression, you make a cast, and the CBCT machine will transfer this cast into this STL. These are the few cases. Another biggest disadvantage before selecting a case, you should remember whether the patient is having a interocclusion distance, proper height is there, because minimal of 30, 40 is too much, minimum of 30 mm of a interincisal distance should be there. Why? Suppose if patient is having a 20 mm of a mouth opening, you'll place the surgical guide itself is having a thickness at the occlusal level in between 5 to 8 mm thickness. Agreed? Then we are using the erotor or a contraangle handpiece. Along with contraangle handpiece, drill is there. So the total height will become around 20 to 25 millimeter. Then if the total height of the particular armamentarium is 20 to 25 millimeter, where is the space will go into the oral cavity? Are you getting me? We need a space to enter into the oral cavity along with the surgical guide and along with the all armamentarium. So if the patient is having a OSMF or a restricted mouth opening due to any pathology or any other reason, so be cautious that there should be a proper mouth opening should be there. With sleeve and without sleeve, there is a two school of thoughts. The surgical guide, I think one surgical guide I have given is having a sleeve, metal sleeve. Anybody is having that particular surgical guide? Achha. It is having, yours is having a metal sleeve. Who is having? There is a metal sleeve in the surgical guide. It is having or not? Metal, yeah. There are two school of thought. In this hole, this is basically a surgical guide hole. Madam, see this. This is the point of entry. This is basically a surgical guide. Can you show me that, please? There are two school of thought, whether to go with sleeve or without sleeve. Initially, I was using the without sleeve because when you are going for a guided surgery, when you ask the company person, ki I'm planning for a surgical guide, send me the kit. They'll send you the kit. Then they will ask you, ki, sir, you have a surgical, you have a sleeve or not? Then you'll say, what is that sleeve? Then say, then the company guy will say, ki, okay, we'll send you the sleeve. Single sleeve is costing 1,000 to 200 rupees. 1,200 rupees, like 1,200 to 1,500 rupees. Okay, costly affair. I never use that sleeves in my during the first 2 years. Then the people are asking why you are not using a sleeve, because if we are not using a sleeve during the surgery, this is made up of a resin. Agreed? This is resin, soft resin. This is soft resin. So if I enter into this drill hole, might be possible that my drill cutting thread will cut this resin and the resin will enter into the socket. That can lead to the chemical reaction. Might be. People were asking me, this can happen. I said, okay. Then I asked asked to the company people, what is in how much money you will give me the sleeves? They give me a very fantastic quotation. Then I said, send me one sleeve. They sent me one sleeve, and after a month, I created my own sleeve, bulk. Kilo, in a kilo, you can purchase in a kg. I'll show you, wait. Why? Because I'll tell you, why in Asian countries now, we are not having a proper infrastructure. That's why the other countries, if we are importing anything from any other country, it will cost a lot. Import duty and everything. Then I was like, why to pay for this simple thing? I'll show you the sleeves. BioHorizon, I think everybody of you heard about a BioHorizon company. Madam, you can purchase in 100 grams as such, these sleeves. See, these are customized sleeve. Whether you want an ostium implant, whether you want a dentium, add-in, you name the implant company, that implant will fit into this sleeve. This, yes. Why they are charging so much? First is we are importing the particular product from them, and they have made up of titanium. What is the use of titanium? Why? This surgical guide is going to rest in a patient mouth only for 10 minutes. So there is no need for a biocompatibility. This surgical guide is not going to last for a month or a 2 month, for a 10 minutes, unless surgery is done. Agreed? Then why to use titanium? This is stainless steel. I won't tell you the cost, but I printed it in a kilo, means kg wise. So, in a kg you can purchase 1 kg costing such a such. Okay. So my advice is to go with the sleeves now. If you are going for a guided implant surgery, better to have a sleeve. Don't go without sleeves. This is basically a surgical protocol. This is a surgical guide, and through the sleeve we are entering. Can you see this upper part of this surgical guide, this implant kit? This is basically a stopper. Your drill won't go beyond that particular marker. Another thing I missed is, I've told if the patient is having a restricted mouth opening, don't go for a surgical guide because you are not able to enter. What we have done, another innovative thing, we have put a side slit in the surgical guide. Can you see this? This cut, this and this. Here it is open. So you just enter into the patient mouth. If patient is having a 10 or 15 mm of a mouth opening, you just enter into the patient mouth and put your drill along with the buccal mucosa, enter into the surgical guide and start drilling. Then what if patient is completely edentulous? Patient is completely edentulous. Even if you are having an intraoral scanner in your clinic, you can't do anything because the intraoral scanner won't capture the soft tissue, or it won't give the soft tissue reference point. Okay. So what usually people will do, make a denture and they'll put a markers. These are the GP markers. Don't do this mistake, putting a GP markers. No. This is a waste technique. And some people do this. I've seen this metal balls. They place the metal balls. Metal balls will create this kind of artifact. Can you see this artifact? Can you see this streak artifact along with this radio opaque markers? Don't use the metal balls. What to use is the composite balls. Make a 5 mm of a composite ball and put minimum 3 composite balls as far as possible on the denture. Anywhere in a denture. 5 mm thickness or a diameter composite balls place on the denture, and then ask a patient to bite on a cotton roll while scanning. Bite on the cotton rolls bilaterally and then do the scanning. Once the patient scanning is done with a denture, then ask the patient to remove the denture and scan the denture again for the STL file. One scanning with a patient wearing a denture with a marker, and another scanning the patient, the denture without a patient. So you will get 2 things, DICOM data of a patient wearing a denture and the STL file of a denture only. See, this is if you are using a composite ball, no artifacts. Can you compare both the images? See, there is a lot of artifact, and in this no artifact if you are using a composite balls. This is a very important case. He's a father-in-law of my prostho HOD. Father is a different thing. He's a father-in-law. And the prostho HOD's wife is a very good friend of mine. So we are going for a guided surgery in this case. I was so nervous on the day the surgery was done because again I am saying father-in-law. Father उतना तो चलता है, my father, but father-in-law. We have done the surgery, the guided surgery, all the extractions were done. And patient, this is patient wearing a denture. Can you see? The patient, see these markers. This is the patient wearing a denture. Okay, scanning is done. And see the soft tissue. See the soft tissue separation. This. If the soft tissue separation is not there, we are not able to rest the guide. Soft tissue separation need to be there. See no artifacts on the markers. This is a denture scan denture. Then the surgery, the guide was placed. See the minimal invasive surgery. No blood. Really just a tissue punch, one tissue punch. And see all the implants confined within the bone. Then last is the tooth and tissue supported. If you are not having a distal extension, suppose 3, 4, 3, 3, 3, 4, 3, 5 is present and 3, 6 and 3, 7 is missing. Then these are the distal extension cases. There is a material known as histoacrylic. Histoacrylic. It is a soft tissue adhesive. In a major surgeries, doctor use this soft tissue adhesive. You just have to make a one composite ball and put it on the soft tissue distal extension. Put the histoacrylic, the composite will stick for a moment in a patient mouth and go for a CBCT. This kind of a point you can have, and you can have a distal extension implant placement. Because if we are not having any support on the distal extension, our guide might tap if no distal extension tooth is there. This is a one pterygoid case we have done. See all the implants, this is a distal extension case. All the implants confined well within the bone. So lastly, the mandatory, we need a one guide kit and the subjected to which implant system you are using. Ideally, you should use, if you are going for a dentium implant, call the dentium guy. I want to go for a guided surgery. Send me the guided kit. It is their duty to send the kit to the doctor. Okay. This is a osteum one guide kit. I'll show you physically this one guide kit. So at the end of the lecture, this digital workflow, where can we make mistakes? First is starting from the CBCT. If your CBCT is incorrect, having a n number of artifacts, patient moving artifact, or the scan was 6 to 7 months previous, okay, and the voxel settings are different. Second is the intraoral representation. Intraoral representation means getting the STL files. If the intraoral scan file is not perfect, if the during scanning the patient using the intraoral scanner, patient is having a bleeding or it is the saliva is there, intraoral scanner still not scan the particular patient. Third one is a planning. If you are wrong at a planning, if you are not able to merge both the files, it will create a error. Then is which kind of a 3D printer you are using. How compatible is your 3D printer? How you are dealing with the 3D printer and the resin settings that might lead to the failure of the cases. And for me, the most in a top in a list potential error is a human error. Only the clinician and a person who is making the surgical guide, they can create a mistake. Human error is the in a top list. So if you are not into the surgeries, you are very new, it is not for the beginners. At least try 1 or 2 conventional cases, freehand surgeries, then go for a guided surgeries. So when to avoid the guided surgeries? Restricted mouth opening, avoid guided surgeries. If there is a lack of mesiodistal dimension. Why I am saying mesiodistal dimension? Because this sleeve diameter is 5 mm. Inner diameter is 5 mm, outer diameter is 7 mm. So this sleeve need to be adjusted in the surgical guide. So if the mesiodistal dimension is less than 8 millimeter, don't go for a surgical guide because your guide won't be fabricated. Because there is no space for this sleeve to rest. Okay. So mesiodistal dimension, avoid if the patient is having a lack of mesiodistal dimension. And in cases of a aesthetic zone, if there is no labial cortex, you want to go for a grafted GBR, then avoid these kind of surgeries. Most important is a keratinized tissue thickness. Keratinized tissue thickness should be minimum 6 mm. Because once you are done with the punch, tissue is gone, you want to restore closure will be there. If you don't do the closure, that leads to the peri-implantitis. So the thickness of the gingiva should be noted. Okay. And a patient allergic to the resin. The material what we are using for the surgical guide, it is made up of a resin and actually it is a toxic. It can create a allergic reaction to a patient's. And any other systemic contraindications for the implant surgeries. So the take home message for the guided surgeries, there should be a minimum 3 rigid stops are required which are present clinically as well as in CBCT. Clinically, rigid stops. Rigid stop means which are visible in CBCT and in patient mouth. So in our dentulous cases, suppose we are going for a single unit implant or a multiple number of implants. If the patient is having a 3 teeth in his oral cavity in any arch, whether it is a maxilla or a mandible, we have a 3 static points. Agreed? In CBCT, we are getting those 3 static points. What in case of a completely dentulous? You remember we have put, I've told you, 3 minimal markers on the denture. They are the static points. So you need to have a 3 minimal static points which are present intraorally and in the DICOM data. Only then we can go for a surgical guide fabrications. Okay. So at the end of this digital workflow, the guided surgeries are safe. Yes, I can say 99.99% they are safe. And they are precise and final outcome is much predictable as compared to the freehand surgeries. So I end my presentation here for the digital workflow. In the, I think, post-lunch we'll have a short lecture on a 3D printing. How to do the 3D printing, what not to do in a 3D printing, which printer you should purchase, and we'll fabricate one surgical guide. Any questions? I'm open to questions in this session. Why I put this slide, the Make in India and Made for India? In our next lecture, I'll tell you why I have put this Make in India and Made for India. I have to change this line, Make in India, Made for Global. I'll change in my next slide. I'll tell you in my next lecture. Any questions, sir? Abhi, right now? हाँ. Post lunch, after the 3D printing lecture, we are going for a software. I'll plan the one case in front of you for the surgical guide, and before surgical guide, if you want a demo on the CBCT care stream software, is it? For implant planning or for the endo cases. So first we'll go for a normal CBCT, then we'll go for a surgical guide planning. Fair enough? Thank you. Any questions? Thank you.
Thank you, sir, for that insightful lecture on surgical guides. And ladies and gentlemen, can we have another big round of applause for our both speakers for this morning? So ladies and gentlemen, we can now break for lunch. Please proceed to the Tamarind restaurant at the 4th floor and enjoy. And we will expect to reconvene at 2 p.m. And before the proceeding to the lunch, we expect all to gather at the lobby area for a photograph. Thank you. Also, there's a kind reminder to take all your lunch tokens to the 4th floor as well, and we invite all to visit the trade exhibition stalls as well during the lunch hour. Thank you.